Good evening, everyone. We welcome you all to a MOA Masterclass in association with Maharashtra Orthopedic Association. To introduce today's topic and speaker, I hand over to Dr. Sahil Sanghavi.
Hello and welcome to our Maharashtra Orthopedic Association webinar on the basics of hip arthroplasty. So today we live in the era of revision and specialization surgery, but nothing really replaces a well-done primary total hip arthroplasty. And with this in mind, the basics of hip arthroplasty, a webinar which focuses on the basics, was conceptualized by our Maharashtra Orthopedic Association. And for this, we have a brilliant lineup of surgeons today who will be talking to you about what goes into the making of a perfect primary total hip arthroplasty. So at the outset, I'd like to request Dr. Nitin Bhagli to speak a few words. Sir, you are on mute, I think.
Good evening, friends. It's my pleasure to be amongst you for this basic workshop on basic webinar on basics of total hip arthroplasty. I'm sure you couldn't have found better faculty than what you have chosen today. All are very good colleagues and friends of mine, and I wish this webinar a grand success. I invite the first speaker to start the session in time.
I request my co-convener, Dr. Mahesh Kulkarni, to please initiate the proceedings. So you're on mute.
Sorry, thanks Sahil, and thank you Dr. Bhagli for introduction to this webinar. We got an excellent group of faculty, so without wasting much time, I'm going to request Dr. Sujit Kumar Tripathy to start his talk about medical management of avascular necrosis, which probably is the controversial and most misunderstood treatment in today's world. So.
You're on mute. Dr. Tripathi, you're still on mute.
Yes, Dr. Tripathi, we will be able to hear you now. Can you speak a few words?
Yeah. Thank you, Professor Mahesh Kulkarni, Dr. Sahil, and Maharashtra Orthopedic Association for inviting me to this excellent webinar that you have prepared today. But first of all, I am a little bit surprised because the first topic was on medical management of osteonecrosis of hip. And where it is a basic arthroplasty course, the first topic was related to medical management. Anyway, so first of all, we all know what is avascular necrosis of the femoral head. And now the better term is osteonecrosis. Because many people believe that it is not a avascular necrosis process, rather certain drugs and certain disease process that cause cytotoxic effect and directly cause the death of the osteocytes. So that's why it is better termed as osteonecrosis of the femoral head. But remember that if it remains untreated, most of these cases, almost 70 to 90% of the cases that progresses, it leads to subchondral collapse and arthritis. So that's why it is very essential to interrupt at some point of time, because most of these patients are young individuals and providing them a artificial hip will not satisfy their functions. So coming to a little bit about the pathophysiology, because unless we discuss about the pathophysiology, we cannot understand the mechanism of the drug action here. We all know that broadly it can be classified into two types. One is traumatic and second one is non-traumatic or atraumatic. In the traumatic, it is a direct vascular interruptions that causes a decreased blood flow to the femoral head. Whereas in the atraumatic causes alcohol, corticosteroid, that all causes either fat emboli, or they can cause intravascular coagulations. Either they can block the vessels, particularly the venous blood vessels, those are blocked. That leads to raised intraosseous pressure And subsequently, it leads to compromise in the blood supply. And then when the blood supply is cut off, it leads to necrosis of the osteocytes, and followed by the cartilage cells which are supported by the bones are actually collapsed, and it leads to arthritis. So we all know that there are three modalities of treatment options available for avascular necrosis. One is the drugs that I'm going to discuss today. One is bisphosphonate. We all know that there is a controversy going on related to this drug. Anticoagulants, statin, vasodilators, those are rarely being used in our country, but still those are recommended as the treatment in some of the countries. Hyperbaric oxygen therapy, then the biophysical modalities like extracorporeal shock wave therapy, pulsed electromagnetic therapy. And I'm not going to the surgical part because they have already been well established in some form of stage of the disease that they are established treatment. Coming to the overview of drug actions in osteonecrosis of the femoral head, we have these modalities of drug. First of all, what is the role of enoxaparin, the heparin? It actually blocks the pathway of hypercoagulability. We all know that sickle cell disease, thalassemia, and many other diseases that leads to hypercoagulation state, and that causes blockage of the arterial system. So enoxaparin prevents that process, and hence it halts the progression of the disease. Iloprost, it is a prostaglandin analog that dilates the blood vessels and increases the vascularity. Hyperbaric oxygen therapy, it improves the ischemic condition there in the bone. By that, actually, it promotes the angiogenesis and osteogenesis. Extracorporeal shock wave therapy and electromagnetic stimulations works by two ways. One is it augments the angiogenesis and osteogenesis, and hence it promotes the growth of osteocytes. Statin drugs are also commonly used, but those have two effects. Either it hampers the process by the corticosteroid, which actually leads to hypertrophy of the fat cells. That particular process is halted by, or it is prevented by statins. And in some of the studies, it has been clearly mentioned that it also augments osteogenesis. The last process and the most commonly used drug in our country is bisphosphonate, which acts on the last part, that is cell death, because it inhibits the osteoclastic activity, and by that it augments the bone formations. So these are all modalities of drug that are helpful in osteonecrosis of the femoral head. We all know Dr. Sanjay Agrawala. He has actually widely popularized the drug bisphosphonate. And you can say that he's the pioneer of use of alendronate, particularly in osteonecrosis of the femoral head. He himself has mentioned that he has published almost 4 to 5 articles on AVN, particularly with the use of alendronate in that disease. He has clearly mentioned that it not only improves the pain or functions, rather it halts the disease progress, and it prevents the radiological progressions, and most of the cases are delayed for secondary total hip arthroplasty. And his results suggest that the alendronates are particularly useful not only for stage 1 and 2, but in few cases of stage 3 disease as well. So let us see how it works. I have already discussed that it inhibits the osteoclast activity and thus curtail the bone resorptions. And there are several studies. It has been well studied in the animals, as well as few clinical studies have clearly proven its efficacy. But most widely accepted and the most commonly, that means used study for in support of alendronate is by Agrawala et al. He has used it in 10 milligram per day or 70 milligram per week, and his reports are available within 1 year outcome, 4 years outcome, and 10 years outcome. And if you see the rate of conversion to THR, it is only 2%, 8%, and 33% for stage 1, 2, and 3 osteonecrosis, compared to 65, 69, and 87% in untreated groups. So his long-term follow-up is also quite encouraging because only 29% of the disease collapsed in the pre-collapse stage of osteonecrosis following 3 years of continuous alendronate therapy. So he mentioned that probably we can alter the natural process of the osteonecrosis by giving alendronate. And these are different regimens as used in the studies. Many people ask the question whether zoledronic acid can be used or not. Previously, few animal studies were there, but now one clinical study has already been established, and it has been given for 2 years, and it has also shown very good activity or very good outcome in osteonecrosis of the femoral head. But the problem is that if you read the meta-analysis or the systematic review on bisphosphonate, actually the outcomes are not so encouraging. When we say the outcome of AVN, we evaluate in 3 or 4 forms. One is how much it is causing the pain relief. Second, how much it is improving the function. Third, whether it is preventing the radiological progressions. And the last part is what is the need of secondary THR. And if you analyze properly, only Agarwal study has clearly mentioned that probably it acts on all the 4 phases. But if you see few of the good studies, which are RCTs, they have clearly mentioned that probably it has no additional effect. So that's the problem. When we take into the meta-analysis, Dr. Agarwala's studies could not be entered into the study because those are open label prospective, non-controlled. So there is no control group. So that's why in the level of evidence, it comes as level 2 or 3. So just see the most updated meta-analysis of all animal studies and clinical trials. And I have put the data of only clinical trials which are published on bisphosphonate. If you see the pain score, there is no significant effect. The difference between these 2 drugs, whether they are taking bisphosphonate or not. So there is no difference between these 2 groups. Then coming to the Harish Pro, then there is no difference between these 2 groups. You can see the p-value is 0.17 here. And if you take the femoral head collapse, that is the radiological progression also, there is no difference. And the last part is how much of these patients needed secondary THR. There was no difference. It was only 0.09. So this updated meta-analysis has not taken the data of Dr. Agarwala's because it is a non-randomized, it is actually non-randomized trial and there was no control group. So if you ask the personal experience, many surgeons have sent their X-rays. Basically, if you see the X-rays shared by Professor Raj Sekran, this was the X-ray of one of the pediatrician who presented to in this condition. It is almost type 3 because it has already collapsed here. And just see, this is the pre-bisphosphonate therapy X-rays and CT scan. You can clearly see that it has collapsed on both the sides. Right hip is also collapsed, left hip is also fragmented and collapsed. But see the changes after 1 year of alendronate therapy, who has received 70 milligram every week. And this is the improvement. Everything has healed up. And if you see the MRI, actually the contour of the femoral head is restored. So that's what Professor Raj Sekran mentioned once in one of the conference, that probably alendronate, the efficacy of alendronate cannot be ignored. But these are all personal experiences. And even in my series also, I have seen many patients that the disease progression has not progressed in some of the cases, but I cannot say that it has reversed. So coming to the consensus based on all 3 meta-analyses published till date, despite bisphosphonate significantly improves bone remodeling in animal studies, there is no significant efficacy observed in clinical studies, hence it cannot be accepted. Now coming to the second part, that is the anticoagulant. We divide the AVN into 2 parts. One is primary AVN, where there is a coagulation defect, particularly in antiphospholipid antibody syndrome, inherited thrombophilia, and hypofibrinolysis. Here, actually, hypercoagulation is the main pathway, and the secondary factors are like traumatic and the corticosteroidal alcoholism. So anticoagulants, all these anticoagulants variants like heparin, starting from heparin to fondaparinux, they are applicable only in case of primary osteonecrosis of the femoral head. That means in patients where there is a fibrinolysis defect is there. And all these 4 studies, recently it has been published, the meta-analysis by Go et al. In 2017, they noted that particularly in primary osteonecrosis of the femoral head, the disease is not progressing and it has a beneficial effect. So they concluded that anticoagulants could be used for primary osteonecrosis of femoral head. However, it cannot play a protective role in secondary osteonecrosis of the femoral head. Coming to hyperbaric oxygen therapy, let me clarify that in most part of the Europe now it is an accepted treatment because they have seen that it has shown very good outcome, not in terms of their functional outcome or pain, rather it has delayed the progression of radiological progressions, and many patients, it prevents the development of osteoarthritis who need THR. So this is the overall trial. But if you see the analysis of the conclusion of this meta-analysis, they have noted that the hyperbaric oxygen therapy had 4 times higher efficacy compared to the control group. However, on subgroup analysis, they found that the clinical effect is only seen in the Asian population and not in the non-Asian population. The reason is most of the patients here, the sample size is more from the China and Taiwan. So that's why actually this meta-analysis is totally deviated towards the Asian part. And this is what the meta-analysis concluded. The clinical efficacy is clearly seen when the hyperbaric oxygen therapy was given. Statin therapy, let me clarify that statin therapy has never been used as a clinical treatment. It is only used as a prophylactic treatment, particularly in patients who receive corticosteroid for a long period of time. When you give atorvastatin or simvastatin along with the corticosteroid, probably you can prevent the development of osteonecrosis. So the mechanism of action is it reduces the bone marrow adipocyte size and reduces the intraosseous pressure. And the indirect effect, it has been noted that it has some pro-osteoblastic and anti-adiposonic effect as well. So it has an effect on starting. This is the clinical studies. 2 clinical studies are available. In one study by Pritchard et al. Published in Core in 2001, they noted that the incidence of osteonecrosis is only 1% when corticosteroids and statins are given, whereas it is around 3 to 20% in patients who take only steroid. But another study contradicted this finding. So, but you can say that based on the clinical animal studies, one can start the statin therapy, and it has shown efficacy in the animal studies. Coming to the last, that is iloprost. Actually, it has been used few studies and it has shown efficacy, particularly in the bone marrow edema syndrome. But there are severe side effects like headache, nausea, and temporary inflammation in hip pain, and there is limited evidence in support of this. These are all biophysical modalities available, like electromagnetic stimulations and extracorporeal shock wave therapy. And Wang et al., who actually first promoted the use of extracorporeal shock wave therapy, he noted that there is 79% improvement compared to 29% in core decompression bone grafting group. That means it is doing better even than core decompression bone grafting group. And the mechanism of action we have already discussed earlier, it promotes osteogenesis and neovascularization. And he mentioned that probably the isolated extracorporeal shock wave therapy is equally efficacious, and there is no added advantage when we combine with cocktail therapy, like adding hyperbaric oxygen or alendronate. So this is the recent meta-analysis published in 2017. It has clearly mentioned that there are only 4 or 3 high level of evidence in support of extracorporeal shock wave therapy, and they all have reported a positive outcomes. So this is how the Harish score, it has improved from 43 to 92, 78 to 97. All these studies have improved the Harish score. The VAS score has also come down from 9 to 1.2. You can see that. So the consensus on extracorporeal shock wave therapy in osteonecrosis is that it improves the hip functions and relieves the pain. But the bone marrow edema is also significantly relieved, but the necrotic bone could not be reversed. And this technique could slow or even block the progression of ONFH and therefore reduce the demand for surgery. However, mixing with other conservative modalities could not improve the curative benefits of ESWL. But again, the conclusions should be interpreted carefully because there are low quality evidence in support of this. So this is the pulsed electromagnetic field therapy. It has already been proven in few low quality evidence and very less number of patients that it is effective. But again, come to the conclusion, if you ask me, I would agree with Michael Mont, who published recently in 2021 about the 5-year update on AVN non-traumatic osteonecrosis management. Where do we stand today? I would say all the medical management still holds as a insufficient evidence to be used in osteonecrosis of the femoral head. And if at all one is inclined to use this, probably it is appropriate for rare occasions where it is a small sized lesion, medially located lesion, and which may heal without surgery. Thank you.
Thank you very much, Dr. Sujit.
Thank you.
We'll see if there are any questions coming through OrthoTV. We will take them.
Yeah.
Any questions from the panel?
Any experience with Ecosprin or iloprost and statins on a personal experience?
Yeah, there is one study only available on Ecosprin, acetyl salicylic acid. Yeah. Sahil, there is one actually trial available on acetyl salicylic acid, that is Ecosprin. They have given around 75 to 100 milligram. And they have noted improvement. Only one clinical study is available. There is improvement in terms of clinical improvement and radiological improvement. But again, the sample size is very less, only 20 or 25 cases.
Yeah, can I make a comment on this this topic, Mahesh?
Yeah, please. Sure.
Yeah. So it's been our observation that there is a debonding between the subchondral bone and cartilage. So all your conservative procedures may not actually work. And what we observed is that the location of the lesion and the size of the lesion are the 2 factors which probably are very key. So if you have a laterally located lesion, which is in the weight-bearing area, and it is 50% or more of the femoral head, these are the ones who will invariably do badly with whatever you do and eventually end up in a THR. And somebody who's got a more medially located lesion, which is less than 50% of the femoral head, then they may do well irrespective of whether you put them on treatment or not. So I personally don't think that core decompression, bone grafting, all these have worked because of the procedure in itself. It's probably related to the original extent and location of the avascular necrosis lesion that is not talked about in any of the studies.
Yeah. Dr. Krishna, you are absolutely right. I totally agree with you. And if you see the recent studies, particularly published from Japan, they have proposed one classification that is called as Japanese Orthopedic Association classification. And it has contradicted that they are not obeying any other classification, in fact, because they have proposed it based on the location and size of the lesion. So A, when it is less than medial 1/3 only involved, B, when it is 2/3, and C, when it is involving the lateral weight bearing zone. And you are absolutely right that some studies, recent studies have taken the Japanese Orthopedic Association, and they have noted that particularly only one treatment that is effective is mesenchymal stem cell installation along with core decompression. And the second one is vascularized fibula graft. So I would say these two techniques we can rely upon.
Thank you. I think we'll move to the next talk now. I'd like to invite Dr. Harish Bhende to give his talk on preoperative templating for total hip arthroplasty.
Thank you.
Thank you, Sahil. Let me thank Mahesh, Sahil, and MOA to allow me to present this talk on the basics in THR. I'll be talking about templating of the hip before surgery. Now, we many times hear these things after the surgery from some surgeon that, oh, we got stuck on a table. The acetabular was too small and we couldn't do anything. We had to over-ream and ended up into a problem. Or, oh God, this was a tough one. I could barely manage to get the hip reduced. It was so tight, I couldn't reduce it. Similar exclamation when you hear at the end of the surgery, you know that either the person has not done the templating, or more often, they may have done the templating, but it is not done properly. It is done wrongly. Now, what is meant by wrongly done templating? Because when you talk about templating, there are many problems which can happen because you don't realize the limitation of templating an X-ray or templating for a hip replacement surgery. So basically, if you ask the surgeon, any surgeon, what does the templating tell you? Most of them are worried about size of an implant. What size cup and what size stem I am going to use. But in fact, templating tells you much more than this. It tells you about position, offset, limb length discrepancy issues, how to address them, in which way you have to add or reduce limb length, and eventually a selection of an implant, because sometimes you may need to have a long stem or a high offset implant. And if a particular system doesn't allow you that, you may have to change the implant company and ask implant from some different company, which can give you a high offset implant in some cases. So it is very important to do this templating well. And for that, we need to have some basics which must understand. Now, what things are not shown by templating, or what are the fallacies of templating? We don't realize this very often when we put a template on an X-ray. The first thing is a magnification effect. Usually we have an X-ray which is nowadays a digital X-ray. We very rarely get now a regular X-ray film which is normally developed. And this digital X-ray basically depends on what is the size of film the radiologist will give you. It could be a same pelvis with both hips can be printed on 8x10 or 10x14 or maybe 12x15, any screen. And accordingly, the actual bone size may get significantly magnified or may get significantly reduced. Now, we must know exactly what is the magnification. And another thing which people do not realize is at the bottom, they have given a magnification thing, but that is not actually the magnification of the bone with respect to what you see. It is a magnification or reduction of actually recorded thing on the X-ray film, digitally recorded thing. So that 100% X-ray doesn't necessarily mean we are getting the same magnification as an actual human bone. So there is a simple way of overcoming this magnification effect, especially on a digital X-ray, and we'll come to that. Second thing is we have to realize that when you do a templating, say for example an acetabulum, by putting a acetabular template on the X-ray, What we are recording is the vertical diameter of acetabulum, and what actually matters in actual implanting the implant is the anteroposterior dimension of the acetabulum, that is the distance between the anterior and posterior column of the acetabulum. And usually that is little smaller than a vertical diameter. So more often than not, you may template for say 50 size millimeter cup, and you may end up putting cup which is maybe 48. And if you try to keep on reaming to reach 50 or 52, you may end up over reaming either a front or a back wall. So we must realize that templating shows us the vertical diameter, and actually on table, it is the anteroposterior diameter of the hip, which decide which implant size you're going to use. And a third very important thing is the soft tissue laxity, which again is not considered by the surgeon. Say, for example, when we have planned and templated that patient require, for example, size 8 femoral stem with a medium size head, we have to realize that when you actually do the surgery, depending on what type of patient, like young lady patient, which has got a good flexible hip joint and a condition like say TC fracture neck femur, which you want to convert to THR, would have so soft tissue, so lax soft tissues that you may end up putting a much longer neck length and elongate that thing. On the other hand, the patient who has got a excision hip or patient who has got a significantly tight hip because of fibrosis or previous surgery may have got such a tight structures that you may not have or may not be able to put the planned implant. You may have to go for a smaller or a shorter neck or a lesser offset. So the effect of soft tissue on actual surgery cannot be anticipated and expected when you do the templating. So you have to give some validity for that when you actually do the surgery. So templating is not the final thing. The things may change during surgery also. Now the basic rule of templating is we must have an X-ray which is a whole X-ray of pelvis, not just a one-sided hip which is seen. We must have a magnification strip on a side of an X-ray, and the position of the hip must be slight amount of internal rotation, maybe about 10 or 15 degree. If the hip, when you take an X-ray, usually is in external rotated position, the neck of the femur is pointing anteriorly, and you can get a false idea of the offset which looks like very small. So basically, when you take an X-ray for templating, make sure you get a full whole pelvis, magnification strip is there, and a position of hip is about 10 degree internal rotation. So this is an X-ray, for example, if you want to template, we normally draw certain things like we do inter-teardrop line, which is the basic line from which all the measurements are done. Then we take the center of the lesser trochanter on both the sides and measure the distance between the inter-teardrop line to the center of the lesser trochanter. Now this is your limb length discrepancy, which is an actual limb length discrepancy which you have to correct. A patient's leg may appear shorter than what it is because of the adduction deformity on that side, and in which case you may have to realize that we should not over lengthen the leg. This actually gives you this measurement, exact amount of bone shortening, and that much amount of lengthening you need to do on table during surgery. Then you look at a proximal migration of greater trochanter on both the sides. You know that much amount of migration you have to correct. Then you come on the acetabular side, you put a 45 degree inclination line a little away from the teardrop, and this is a line on which you can then put your template of a cup. We can see in some subsequent slides. Now this line basically tells you that if you put your cup at 45 degree inclination, then how the cup will look on the X-ray, and do you need to actually change this to little less or little more inclination. Now this is an inclination line. Usually when you do templating, we don't worry about templating again the post-surgery X-ray, which also you should do. Like this patient after the surgery, this is the inter-teardrop line. These are the two lesser trochanter points. You can see that the limb length is corrected after surgery. This was cemented THR, and you have got inclination line, and you can see that your cup has been actually placed exactly at 45 degree inclination as you have planned initially. So basically you have got also distal migration of trochanter to allow good movement. So if you do this templating exercise or planning exercise on the post-op X-ray, you actually come to know whether you have done things right or wrong. Now, this is how the acetabular template is put. And you can see that this is a template which is put on the left side in exactly 45 degree along the inclination line. And you can see that the template actually go over the bony margin of the acetabulum. Now, if you put the acetabular cup slightly or template slightly more close, like at 40 degree, you can see that the lining of template and the edge of acetabulum on bone matches much better. So, and edge of the template also comes to the lateral end of your acetabulum. So this actually tells you that during surgery, when you want to put a cup, if you put cup, which is say size 56 according to this template, so that the lower end of a cup is just at the teardrop level or just on the transverse acetabular ligament, and a lateral edge of a cup, if you put at the lateral edge of your acetabular edge, then you automatically will get 40-degree inclination. So these anatomical landmark which you see while templating helps you during the surgery. So it tells you exactly that during the operation, if I put my cup flush with the superolateral edge of acetabulum and lower end on the TAL, I would be 100% putting my cup and 40-degree inclination. So templating is not just what you see on table about size of a cup, but also which way with respect to the anatomical landmark, you will get the required inclination or anteversion. This just an example showing 58 cup in this particular acetabulum will be too big because it is removing too much of a bone, and the smaller cup will be looking very small. Now, when you talk about templating on a femoral side, what we need to do is we need to draw a vertical line along the shaft of the medullary cavity and see where the line exits along the neck. Usually, if there is no deformity of the proximal femur and the femur is normal, like in a case of primary OA or AVN, this line exit at the point of attachment of piriformis tendon or piriformis fossa. So once you have drawn this line, then you take a template, and each template also has got a vertical line, which is the axis of your implant. So you match the axis of an implant with the line which you have drawn and start sliding the template downward, so that, as you can see on a yellow arrow, the medial edge of your templated implant matches the calcar of the actual bone. Now, you have to go only that much down and then see what is your fit or fill in the distal part of a bone and a metaphyseal part of a bone. So if you can see that in particular size, the metaphyseal and a distal part is filled very well, and the medial calcar of the implant or template is sitting well on a calcar of a bone. That means your position of a template is very good. And then you can look at the head points of the template. You can see that on an X-ray, there is a black dot, which is shown by a horizontal arrow. Now that black dot is actually a center of the femoral head. And there are 3 hollow dots along the template. And these are the 3 hollow dots which gives you the position of center of the replaced implant. And it is the central hollow which is matching to some extent with the black dot. If you use that, you will get the equal length, but your offset will be a little less in this particular situation. And it tells you that if you use a long neck head, which is the proximal most hollow dot, that means you will be creating much more or more accurate offset, but the length will be maybe a couple of millimeter more. Now, as I mentioned, these are just guideline. These marks and dots will be accurate only when, number one, your magnification is right and it is same as your template. And number two, your rotation of the hip is adequately decompensated. That is, you are taken an X-ray with about 10 degree of interrotation. So you will not get a false shortening of the offset because of the excessive anteversion. Now, you can see this in subsequent X-ray, and I explain you exactly what I mean by all these statements. Now, this is an X-ray, which is an AVN case, and patient was planned for surgery because he had a lot of pain. And you can see on the left-hand side, this is on the left-hand side, you can see that this is a magnification strip. Now, how do you make it? It's very simple. You can take those pins, take any plastic scale, which is 1 centimeter scale, and on each centimeter line, you put a small pin and you stick it with a adhesive tape. Automatically, each pin is about a centimeter distance. So it is very easy to make. Anybody can make it on your own, and then stick it at the level of the trochanter on the side of the patient's pelvis. And when you take an X-ray, make sure that this adhesive strip is included into your X-ray film. So this is my magnification strip, and it tells me that each distance between each pin is about 10 millimeter. So whether that X-ray is shrunk to a smaller place or a expanded to bigger place, it doesn't make a difference. I know exactly how much shrinking has happened. Now, when you get an X-ray on a large film and you put a template, each template has got a magnification scale on the side of a template. What we normally do is put the scale of that template on this magnification scale of an X-ray. And if they match identical, that means your X-ray is expanded or enlarged exactly as much as the template is. You don't have to worry whether it is 10% or 15% or 20%. If the template scale is bigger than this scale on an X-ray, that means your template is expanded more and X-ray is shrunk because maybe radiologist has tried to get an X-ray on a smaller film. On the other hand, if your template scale is smaller than the scale of an X-ray, that means your template is not magnified enough. Your X-ray is magnified more. And this is the simplest way which anybody can do to make sure that your X-ray is expanded as much as your template. And if it is not, how much is the difference which is going to get? Now, next thing you come to look at the lesser trochanter, it should not be very prominent. It should be slightly hidden. So that tells you that it is adequate amount of internal rotation is given. Then that's the center of head. And this is actually the vertical line which you talk about. And this gives you an approximate offset. Now, this many times you may have to compare it with the opposite side. Now, you may ask me what happens if the patient has got an external rotation deformity because of arthritis of hip. And then obviously you can't get a proper X-ray. Like in this particular patient, you can see that the patient has some amount of dysplasia, significant lateral subluxation and adduction deformity with significant amount of external rotation. You can see that lesser trochanter is quite prominent here compared to the opposite normal hip joint. So here what happened is because of the excessive external rotation, we cannot get the hip internally rotated because there is a fixed external rotation deformity. So what like this patient. So this is the center of rotation of hip, which can approximate say. And if you draw this vertical line, you can see that on a normal side, that's a normal acetabular offset, while on an affected side, it looks very small. Obviously, it is not that small. It is just a apparent appearance because the hip is excessively anteverted because of external rotation and some amount of valgus position. Now, in this situation, you may go on the opposite side to do the templating and try to see what offset you will need to use in this particular patient. So it is important to have this understanding that you may not always get the most ideal X-ray to template, especially on a femoral side. And in which case, you may either use the opposite side X-ray or you may have to go just by your judgment on table, where you measure on table the actual offset and neck length when you are doing the surgery. Now, if you want to go on acetabular side in this particular patient, it's a dysplastic hip again, and you can put the cup in a normal anatomical position where the lower end of the cup is exactly on a teardrop line. So if you put a cup, you have to realize that you have to build the superolateral part because acetabulum is much wider and bigger. So you should be mentally prepared to use a bone graft, usually procured from the same femoral head, put the graft inside and then ream below the graft and create a new acetabulum, which is partly supported by the acetabular graft and partly by your host bone. But more often than not, what we do is we go a little higher, try to seek a better bone and a better quality host bone. So we can usually accept a little higher position of acetabulum. And you can sometimes get a primary cup even in a dysplastic hip. Maybe you have to use a smaller cup to get a better containment. Now, what happens is if you go proximally, you are actually going little higher and automatically you may not be able to use the same offset as you plan or template on the opposite side, because if you use the same offset, you are gone proximally, automatically your tissues are going to be a little loose and lax. To compensate for these lax tissues, especially in a female patient, as this was a female patient here, we may have to use a higher offset implant or a longer offset or a higher length implant. Unless we have mentally planned for that, you may not be able to actually use and actually go ahead and do a good job, because you start using the same offset implant and your cup is slight proximal, your tissues have become lax, your abductors have become little weak because of proximal migration of your center of rotation, and you'll end up having a dislocation. So more often than not, people then put this dislocation saying that, oh, this is a dysplastic hip, it has to dislocate anyway. So it dislocated, so what? Now, it doesn't have to be like that. If you calculate from your templating that, okay, I have to increase my offset, not reduce it, then you may end up using a different implant company, because you may use an implant company which may not have option of a higher offset implant. And if you don't realize that this is an antevoted hip, as you can see the previous X-ray, you may end up thinking that it has very small offset, but that's not a real case. So this is an actual post-op X-ray of the same patient. And you can see that if you just have a bird's eye view of this two-side hip, you will suddenly feel that, oh my God, this hip looks too big. The replaced hip looks too big and too large compared to the normal side hip. But we have to realize that the acetabulum has been migrated proximally by almost 17 millimeter here, because we wanted to use the smaller acetabulum at a higher level with a good quality bone. So I had to go, or we had to go for a high offset implant, and an implant which has got a longer neck length. Now, if you drop this inter-teardrop line, and then you can look at the position of these trochanteric tip, you can notice that even though apparently it looks like a bigger hip and a bigger implant on the femoral side, the actual limb length discrepancy is corrected quite well. And a patient has got equal limb length on both the sides. Here, we had to go for an offset and higher implant, especially in a female patient when the tissues are very lax. And as I mentioned in my earlier part of a lecture, that the soft tissues are very important, especially in a female patient. In a soft mobile patient, many times, if you don't have a high offset implant, you may end up putting a longer neck length and may elongate the neck. And then the limb length discrepancy issue can haunt you, and it can haunt your patient. So in this particular patient, as you can see, we have planned to use a high offset implant so that we can get equal limb length, and the patient has got a very good function. She was very comfortable. So you can see notice the high offset here. Now, templating is not just the pre-op planning. Pre-op planning actually involve much more things than template. And let me just enumerate what other things which we need to do when we actually start the hip replacement surgery and before the operation. The pre-op planning also includes checking for the correct indication for surgery, deciding the type of prosthesis. Do I need cemented or a non-cemented or hybrid? We must find out the associated problem with the patient, whether the patient has got soft tissue contracture, previous scars, previous bone loss, severe osteoporosis, presence of spinal deformity or a knee deformity, which can cause and affect the knee surgery. We also need to plan whether we need to have adequate medical workup for the patient. We must arrange for required implant and augment. As I mentioned, you may need a small implant, especially in a female patient. You may end up using 38 or 40 millimeter cups, and these cups are not easily available. Usually non-cemented cups are available from the size 44 or 46. So you have to ask the company specifically in some cases, like the one which I showed you, to keep small cups available to you on table. Otherwise, you may end up having a big trouble on table. And you have to educate the patient about how to sit, how to talk, etc. So basically, templating is not the end of pre-op planning. It needs a lot of things, but templating is an important part. And if you do it well, you can get a lot of information which can prevent the risk and complication of your surgery. Thank you. Any questions?
Yes, Sahil, please go ahead. Yeah, thanks.
No, so nothing from my side. Any other questions from the faculty members? Apart from the high offset requirement, is there any other thing on templating that would prompt you to choose an implant from another company than your standard company, apart from the high offset stems that you mentioned?
The other thing is the shape of an implant, which we need to see. I haven't included that because sometimes you have got a very narrow cavity and you may need to have an implant which is a narrow implant. Some of the implants are quite broad proximally and they may not be, they cannot be inserted in the narrow or small patients. So you may need an implant which is a narrow tubular implant, like a C-stem or like a extra stem. Sometimes the implant, maybe cavity is too big. And we may try to use a non-cemented and end up putting a biggest non-cemented, and it create a problem because we may create intra fractures. So in these cases, we have to keep a cemented option available on table. So basically, this templating tells you not just the size, but also the orientation, the inclination, whether you need to put it proximally or distally, whether you have to compensatory have higher offset or higher neck length, sometimes you may have to use a modular implant because there may be deformity in the proximal femur, and you may need something like an S-ROM where you have to use a dissociation of the metaphyseal component and a long stem component, which allows as much rotation as you want. So all these things have to be assessed during the surgery. And as I said, we are normally used to one type of an implant from X or Y or Z company. But during the surgery, not all companies provide all options. And you have to be conscious in taking a decision whether I want to use some different type of implant so that you can change the company, maybe just for that case, because you don't have options in the company which you use.
So I guess a cemented stem, who are the proponents of cemented stem, would sort of say that a cemented stem would get you out of all these problems because you can park the stem where you want. You can either sink it or leave it proud and adjust the leg length and offset. And the other thing, Sahil, I wanted to mention was some of the companies, the smallest implant size, the offset tends to be too big for the small statured Indian patients. So some of the smallest size stems, say size 8 in say, should not name, but people should understand, Korea size 8, the offset with a minus head would still be high for some of our patients. So in these cases, you need to plan preoperatively and think of using a stem by another company which has got a reduced neck length. So that will reduce the neck length and it will make life much easier for reduction as well. So I think these are small things, as Harish has mentioned, but cemented backup, I think, is essential for me as well. So shall we move on, Sahil, with Krishna Kiran's talk? Because
yes, sir.
Yeah, so we request Dr. Krishna Kiran to share his knowledge about choosing bearing surfaces and what matters in today's day and age.
Thank you, Mahesh. Thank you, Sahil and MOA for this invite. So my brief is to talk about evidence-based bearing selection in total hip arthroplasty. The interesting thing about normal articular cartilage is that it is a compliant bearing with a very low modulus of elasticity, and it has ability to resist high deformation forces. And it has got a very low coefficient of friction, which is achieved by 3 lubrication methods: the electrohydrodynamic and microelectrodynamic, which happen in the swing phase, and the squeeze film lubrication, which happens during the stance phase. And by and large, the articular cartilage of the hip has got fluid film lubrication. That is, there is a fluid film between the 2 opposing surfaces throughout the movement. And a low surface roughness of 2 microns indicates that there is almost no wear when a hip joint is normal. So the ideal bearing will fall short, but must be somewhere closer to that of the articular cartilage. It must have a low wear with a limited immune response. We must be able to use a sufficiently large head to allow good functional activity. There must be low friction and no noise. The joint must be chemically stable and fracture resistant, and it must be able to resist abrasion. So with all our shortcomings, the cumulative survival at 13 years is still 93.2%, so which is a very predictable and successful operation. The younger colleagues must understand what is a fluid film, what is a boundary, and what is mixed lubrication. Just to give them an idea, as the coefficient of friction comes towards decreases, the Sommerfeld number, the so-called Sommerfeld number, approaches 1. That is, a normal articular cartilage is near 1, where there is complete fluid film lubrication. The hard-on-hard bearings are closer to the normal articular cartilage, where there is a boundary, a mixed type of lubrication, while the metal-on polyethylene is a boundary lubrication rarely, but more often it is a sort of a mixed lubrication type of pattern, which is seen in total hip arthroplasty. One must also be aware of the different wear modes. You have 5 different wear modes. You can have wear between the surfaces which are meant to articulate with each other, that is the adhesive wear. You can have abrasive wear because of foreign body. You can have wear because of articulation of the surfaces which are not meant to articulate, which is because of impingement or backside wear, which can happen. And all these can lead to a premature failure of a total hip arthroplasty. And why do hips fail? The hips fail predominantly because of aseptic loosening due to osteolysis secondary to implant-derived wear decrease. So this is all the data we have from the past generation of total hip arthroplasties. And this wear-induced osteolysis is typically associated with bone loss, and 5% of failures at long term are bearing related. So it's a significant number which can be reduced if we choose an ideal bearing. So when we look at the relationship of wear rate and osteolysis, so this is a landmark paper which suggested that osteolysis was rarely observed at a wear rate of less than 100 microns per year. And if the wear rate was more than 150 microns per year, the process is at a higher risk for aseptic loosening. Mind you, all this data is with the conventional polyethylene, which we hardly use in our modern total hip arthroplasty. So they found that a 25-year survivorship of processes with wear rate less than 100 microns per year exceeded 90%, while the 20-year survivorship of processes with a higher wear rate, more than 200 microns, was below 30%. So it's an important parameter which one must look at while selecting the bearing. And when we look at wear rates among different bearing surfaces, we have this order where the metal on conventional poly is closer to 200 microns and the ceramic on ceramic is less than 1 micron per year. So it is not rocket science to derive that any bearing which is not a conventional polyethylene, the metal on cross-linked poly, metal on metal, ceramic on ceramicized metal on cross-linked poly, and ceramic on ceramic, all have got the wear rate which is below the osteolysis threshold of 100 microns. And now we need to choose among these what bearing we must use. So the conventional polyethylene is hardly used in any of the total hip arthroplasty. I can only think of the dual mobility sockets from certain companies and some cemented liners which still continue to be conventional polyethylene. The cross-linked poly is probably the gold standard as far as modern day total hip arthroplasty is concerned. And when we choose the cross-linked polyethylene, we must look at the radiation dose which they have been subjected to, whether it is moderately cross-linked poly, whether it's a highly cross-linked polyethylene, and what is the radiation dose that has been used, whether it's 5 megarads or 10 megarads, because all this will have influence on the mechanical properties of the polyethylene. You have two types of post-radiation thermal processing in order to reduce the free radical problem, and that is either through annealing or remelting. The annealed polys are typically slightly stronger than the remelted polys, where the yield strength is compromised a bit at the cost of removing more of free radicals. And the post-radiation sterilization also plays a role. The most important point, however, is that the rate of revision at 16 years for XLPE was 6.2% versus 11.7% for non-cross-linked polyethylene. So cross-linked polyethylene, I must say, is the cornerstone for total hip arthroplasty. And several studies have looked at 10-year survivorship and shown that the survivorship is more than 95.3% for XLPE with a head size of more than 32 millimeter. You have a 40 to 60% reduction in wear with cross-linked polyethylene. And the minimum polyethylene thickness with XLPE can be reduced to almost 3.9 millimeters without compromising wear. But for reasons of strength, at least 5 to 6 millimeters of minimum thickness is preferable. So the head size is typically governed by what size socket you have and what is the minimum polyethylene thickness you are able to use. And this total hip arthroplasty using cross-linked, highly cross-linked PE in patients younger than 50 years with a minimum 10-year follow-up had 100% survivorship, which shows encouraging data even in the younger patients. Now, which head should we choose? Whether it should be a ceramic, a cobalt chrome, or oxinium heads? This is based on several factors like corrosion resistance, hardness, surface roughness, strength, scratch resistance, and effect on trunnion. And although there are no long-term data on RCTs on COCR versus ceramic on XLPE, the inherent properties of ceramic, which makes it more wettable, less prone to surface scratching, and a higher corrosion resistance as compared to cobalt chrome, indicates that ceramic probably, or a ceramicized metal like oxinium, should be the bearing of choice along with a highly cross-linked polyethylene. Where in adverse condition must be borne in mind, where there is head damage, third body, where there is micro separation and edge loading, because inside the normal hip, the conditions are not always favorable. The XLPE in these situations shows worse performance, so you must be careful when using XLPE in order to not damage the head, not leave any third body debris there, and do your surgery properly to reduce the risk of micro separation and edge loading. And it is sensible to use ceramic heads whenever we are using highly cross-linked polyethylene. Metal on metal has fallen out of repute, mainly because of the failure of the large diameter metal on metal total hip arthroplasties. And it is recommended that there must be surveillance for annually for 5 years. And in patients with elevated cobalt and chromium levels more than 7 micrograms per deciliter, the mass sequence MRI must be done to look at and grade the extent of pseudotumors, if any, in these patients in order to recognize and do early revision wherever indicated. Now, ceramic on ceramic is a slightly controversial topic. It has been shown to have very low wear rate in vivo. However, the most long-term studies are with Biolox Forte, and there is a potential for sudden catastrophic failure with head fractures, which has been reported with Biolox Forte. And there has been bad experience with the zirconia composite, which was done between 96 and 2005. And the fourth generation ceramic Biolox Delta is nearing, I think, 18 to 20 years of clinical use now. And the alumina zirconia composite with strontium aluminate and chromium oxide has shown very encouraging results at 2 to 10 years. And the AJR 2017 has shown a 92.8% survival at 15 years with the ceramic on ceramic bearings. And for the Delta ceramic, adverse condition testing showed no measurable difference in strength or roughness at a simulated 40 years. So the laboratory tests are all encouraging. But there are certain concerns with ceramic on ceramic. All hips undergo some amount of edge loading and micro separation, which happens normally during the swing phase of the gait. And these are particularly susceptible, the hard-on-hard bearings, especially the ceramic on ceramic, to edge loading and stripe wear. And this happens with suboptimal component positioning, inadequate assembly of the components. If you have too much of blood at the junction of the trunnion and the head, or the acetabular cup and this liner, then there is a higher probability that you could have squeaking. It is poorly understood, and we don't know the exact cause of squeaking. And it could be both a combination of edge loading, impingement, and implant-specific problems which can contribute to squeaking. So the ceramic on ceramic, although it has got low wear rates, it's still vulnerable to point loading. Clean assembly is important for ceramic on ceramic bearings. And whenever you insert the liner, you have two different types of tapers, the 10 degree and 18 degree. You must know which taper you're using. Some of the ceramic inserts are more difficult to insert, and it is prone to eccentric seating, and which can lead to the ceramic liner fracture if you're not careful intraoperatively. And revision of broken ceramic on ceramic poses special problems because this has problems of removal of all the ceramic particles, and it requires a thorough synovectomy. And we cannot use metal heads for revising these problems. And this is how it can present with sudden catastrophic failure. And that's how the squeaking of the patient looks like. So a study on estimation of incidence of squeaking and revision surgery for squeaking on ceramic total hip replacement suggested that with a particular type of component, the incidence was higher when compared to other implants. The incidence was as high as 8.3%, and incidence of revision for squeaking in these patients was 1.3%. So this led to the development of modular or pre-assembled components like Delta Motion and the Avascular Delta Cup. And even in these, there were some cases of squeaking which were found, which continued to annoy the patients. The take-home message is the perfect bearing is still elusive. As I told you, the articular cartilage is a fantastic bearing, and we are still searching for that elusive perfect bearing in total hip arthroplasty. Currently, the gold standard is the use of a cross-linked polyethylene with ceramic head. 28 or 32 millimeters seems to be a reasonable alternative for majority of the patients. And if the cup size is more than 52 millimeters, where you can ensure an adequate polyethylene liner, you can use a 36 millimeter head wherever indicated. The ceramic on ceramic advantages could outweigh the risk of noise and fracture in young patients, very young patients, but the care must be taken for ideal component positioning, and intra-operative assembly of the components must be critical in order to get a good successful outcome with ceramic on ceramic. Metal on metal and ceramic on metal have definitely fallen out of favor. Thank you.
Thanks, Krishna Kiran. I think that was a very nice presentation explaining the various factors in choosing your bearing. Any comments, Dr. Bhende or Sanchit?
Very well taken lecture. I mean, the principles are very good. Most of the time, we use ceramic on highly cross-linked poly. Only when the patient is less than 50, we use ceramic on ceramic. And if the patient has any physical deformity in acetabulum like dysplastic hip, where your orientation may not be very good or you may not be very confident, then I don't use ceramic on ceramic even in younger people.
I would agree with that, sir.
Yeah.
What is your choice
again,
of bearing in a younger patient, obviously?
Me, but are you asking me, Mahesh?
No, Dr. Sanchit, Sanchit Mehendale.
Ceramic on poly. I think ceramic on highly
Ceramic
cross-linked
on-
poly, even in younger, so as young as 16, 20, because we know their mechanism of failure. Whereas, as Krishna Kiran alluded to, ceramic fractures in that younger population with a longer period to wear can be quite catastrophic.
Okay. We welcome Dr. Suri as well. I think he joined us for this meeting. Any more questions that Sahil come to your mind?
Also, just the same that what is the personal algorithm or choice that which patients do you prefer ceramic on ceramic in? Or as Dr. Sanchit mentioned, do you still prefer ceramic on poly for all patients, regardless of age?
I used to use ceramic on ceramic quite often, and I must admit that my own patients are doing pretty well at 15 years. So I don't have too many problems with fracture or this thing. Having said that, most of my hips nowadays are ceramic on XLP, and as Dr. Sanchit rightly said, we know the mechanism of failure, and at 18 years, there's not much difference between ceramic on XLP and ceramic on ceramic with respect to
My screen were please.
with respect to the wear and stuff like that. So I use ceramic on ceramic very sparingly. If the patient comes and asks for it, then I do it. Otherwise, I would do a ceramic on cross-linked poly in most of my patients.
Okay. So I think
Do you want to move on?
Next
Yeah.
talk. I'd like to invite Dr. Sanchit Mehendale to give his talk on posterior approach for total hip arthroplasty.
Why can't I see my screen? Can you see the screen?
No, it's still blank. Are you on the last slide or?
No, I think I'm going to stop share and start again. Sorry.
Yeah, just shut off that window maybe and reopen and share it. Yeah.
Better?
Yeah.
Yeah, greetings from Bristol. Thank you, Sahil. Thank you, Mahesh, MOA, and Dr. Bugli for inviting me. So we've decided, Harish has talked about the planning and the templating side of things. We've chosen our implant. Now we need to choose our approach. So hopefully what I'm going to go through is anatomy, talk about the technique with a small video, and then advantages and disadvantages, and then the literature, which you will find is skewed heavily by what people favor, as you would expect, and then my preferences. So the posterior approach hinges on these two important things. So the short external rotators, as they're called, or quadriceps coxae, as is labeled in the modern literature. So the piriformis, the two gemelli, and the obturator internus, and then going on to the obturator externus and quadratus femoris if you need to. And the thing of note is the medial circumflex femoral artery and the branches of the same. So those are the kind of things that it hinges around, and the sciatic nerve, obviously, which you need to protect. And when we talk about approaches around the hip, I sort of have this kind of dial clock in my mind. So end-on view of the greater trochanter. And then you talk about intervals. Anything in front of the tensor fascia lata, between that and the sartorius, would be your anterior or direct anterior Smith-Peterson type of approaches. Between the tensor fasciae lata and gluteus medius would be your Watson-Jones interval. Then you have a spectrum of direct lateral approaches, the commonest being the hard hinge, and then everything posterior, and we have variations on that as well. So that's a simple sort of way to remember about the approaches to the hip joint. What is it used for? So commonest total hip replacements, not in the UK, but in India, I know sort of we use it for hemiarthroplasty, and it's the sort of default approach. Revision hip arthroplasty, periprosthetic fractures, pelvic-acetabular surgery. And it's a really versatile approach. The only thing where it may not be as useful is hip sparing surgery if you're thinking about femoral acetabular impingement and that work. So incision center of the lateral, so decubitus lateral position, you have a great trochanteric approach, and then you split the gluteus maximus, and then your idea is to find the short external rotators. Once you found them, you tag them and then divide them, find the capsule, protect the sciatic nerve, and that's your approach done. Okay, so let's see if this works. So lateral decubitus position again, I do the skin markings quite frequently. It's good for training as well. You go through the skin and subcutaneous tissue and then stay slightly anterior on the fascial lata when you split it. Otherwise, it tends to bleed a bit more. Once you've completed and extended the fascial split, you're now concentrating on the bursa. I don't excise it. I just sort of clear enough space. And then the idea is to find the posterior edge of the gluteus medius. Once you've found that, you can get your finger in and a Langenbach retractor. The next challenge would be to find the piriformis, which is demonstrated there. You go between piriformis and the gluteus minimus, and then go over the superior edge of the acetabulum, and I put a blunt Hohmann retractor there. Then that gives you a nice view. And then the interval between the quadratus and the inferior gemellus. So you tag your external rotators. I tend to take it out in 2 layers. I do infiltrate with a mixture of bupivacaine and adrenaline, which does bleed less. And then that once you've retracted that, you've got the capsule in vision, and we talk about the sort of retractor to retractor. So the knife should touch both Hohmann retractors, and then you get a big enough flap, because the posterior repair is the crucial bit in preventing dislocations. You put a stay suture through the sort of free edge of the capsule, and you should end up with these two so that you can then split them and reattach them to transosseous repairs. There's the deep branch of the medial circumflex that is coming in. And then if you need to, you can put a stay suture in the quadratus femoris and extend your incision. If needs be, go beyond, and also take the gluteus maximus if needs be. So the posterior approach advantages, everybody's familiar with it. It's one of the commonest used approaches. It's extensile. You can do pretty much, so you can go all the way down to the knee if needs be. It preserves the abductor mechanism, the gluteus medius being the most important muscle. You don't touch it, so that's great. It gives you fantastic exposure. I mean, I think with all the approaches, it is probably the most unparalleled approach, sort of visualization, and you get 360 degrees exposure of the acetabulum. Useful if you're thinking about revision surgery as well. And in those cases, if you want to do any ILL reconstruction, this is great. And then it's an easy access to the piriform fossa. We know that some of the component malpositioning that occurs with the lateral approaches is because access to the piriform fossa is difficult, which is the one in line with the femoral canal. And so as you can see with that pin marker, that if you get entry through the piriform fossa, not so much in uncemented hips, but certainly key in cemented hips to get adequate cement mantle all the way around, piriform fossa entry is the key. And this is directly in line. So the risk of perforation of the cortices and things like that is very minimal. There are some disadvantages. You need assistance which is skilled, because the leg has to be maneuvered in multiple positions depending on what work you're doing. Orientation, especially again in the UK, where most people are trained on the direct lateral approach for hemiarthroplasties to start off, it can be a bit tricky and almost disorientating. The sciatic nerve is at risk. Theoretically high risk of posterior dislocation, although this is more traditional, and most modern studies would show that it's pretty much identical. And if you're using it for any hip preserving procedures, there is a risk of avascularity if you damage the deep branch of the medial circumflex femoral artery. Lots of literature around this, and traditionally the debate was between the direct lateral approach and the posterior approach, and Pellici's study was the crucial one, which showed that with the posterior repair, enhanced posterior soft tissue repair, you can minimize the risk of dislocation through the posterior approach. And then the Cochrane database review again showed that more evidence is needed before you can conclusively say one approach is better than the other. Then there came lots of variations and alterations on the theme. So within the posterior approach, they talked about the piriformis sparing approach. You have the trochanteric flip for hip preserving surgery, and then the minimally invasive approach. So you don't have to have as big an incision. All of these were aimed at function, early recovery, and was supposed to enhance recovery pathways, if you like. And then there is something called the super path or spare, which is the sort of spare piriformis and obturator internus and repair the externus approach, sort of popularized in Exeter. And these are variations on theme. None of them have actually shown big benefits, but again, you have to take whichever studies you want to decide on the benefit. Most of them have a learning curve. Piriformis sparing approach, we've talked about that, and this was the initial study. So it was quite popular sort of about 10, 15 years ago, that a sort of variation of the posterior approach. And then this was the follow-up study, 10-year studies, which shows that there is actually, apart from some minimal injury to the piriformis, and in some cases you can't even avoid even that because of the rasp, there is no other functional benefit to doing a piriformis sparing approach. As I said, the traditional battle was between the direct lateral approach and the posterior approach. And then there is the new kid on the block, the direct anterior approach. And everybody, again, more across the Atlantic sort of, and this is more a American thing, not so much in vogue in the UK, but the direct anterior approach and early functional recovery, less pain scores, all benefits that you would want to get the patients out of hospital as quick as possible. But then you look at the National Joint Registry figures for England and Wales in 2020. And again, the posterior approach is the most dominant one. So again, the two main approaches used here are the posterior approach and the direct lateral approach. So about less than 1%. And again, even within that, if you see, there's equal distribution between hybrid, cemented, and uncemented. And if you look at the higher proportion of direct anterior approaches, which is 2%, at max, it is still for the uncemented hips. So I put it to you that cemented hips, I think all these sort of modified approaches are not that great. Yes, it can be used, but there is a big learning curve. So the posterior approach is safe and very versatile. These are two studies that I'm going to put. Like I said, there's loads of literature across, and you will have the proponents of direct anterior approach saying that there is nothing like this. It is the best approach ever. There is a learning curve, but if you look at 5 years, okay, does surgical approach influence? And again, for this, you will have loads of studies which show that higher revision rate for some of the approaches, but this Canadian study conclusively suggested that there is no difference whatever approach you use. We go back to the whole thing that you need to know your implant, you need to know your approach that you're familiar with, and then stick to that. And then this was a study from Bristol, again, National Joint Registry based study, effect of surgical approach, huge numbers, so 723,000 elective operations. And they concluded paradoxically that the lateral approach for total hip replacement had worse outcomes. Now, I'm always slightly cautious, although it's a study from Bristol and our team, I'm always slightly cautious about registry studies because they are not nuanced. They're sort of big numbers, but at least it gives evidence to say that the posterior approach still remains the gold standard in total hip arthroplasty. As you can probably tell that I'm a posterior approacher, and I put it to you that it should be your go-to approach for primary hip arthroplasty and revision arthroplasty. And hopefully this sort of whirlwind tour has convinced you that this, if you're not using it, this should be the approach that you should use in the future. Thank you.
Excellent. Thanks, Sanchit. Any questions from the panelists for Dr. Sanchit about the posterior approach?
Can I make just a comment?
Yeah.
Yeah. The idea that posterior approach dislocate more usually started from American papers. The hip was initially introduced by Chanley. He was a big name. And this Chanley's hip was copied everywhere else. The American people, because of influence of Austin Moore, more often used to use the posterior approach. Now, Chanley would put his implant, which has got a fixed offset 40 and later on with 45, even in a big patients by doing a trochanteric osteotomy. So he could balance the abductor, weakness. You use Chanley standard 40, 45 offset in a very tall patient. You still can balance offset by, elongating your abductors by getting your trochanteric flip distally. Now, this cannot be done. You cannot adjust the abductor tension by posterior approach. You have to have modular implant for that. So if you are using a Chanley implant and using a posterior approach, that's a recipe for dislocation, because in a tall patient, like if you've got a tall Black American or, a Caucasian patient, you may end up having a very weak abductors and have a much higher risk of dislocation. But if you have modular implant where you can offset and leg length can be, modeled much better, then the risk of dislocation is much less, especially if you have repaired your posterior capsule very well by osseous sutures. So personally, I also use a posterior approach in all cases. I have done anterolateral almost for 4 years when I was in England, but coming back again, I am starting posterior approach all the time, which is probably the best approach today.
Yeah. Dr. Suri, do you want to mention
What do
anything?
you use, Mahesh?
No, I exactly like you. I use a posterior approach mostly. Being trained on the modified hard hinge, I did both of the approaches to begin with, but the change in orientation is quite significant, and I believe that a posterior approach is good enough not only for primary but revision acetabular surgery. So I stick to the posterior approach. Dr. Suri, do you want to?
What? Yeah.
So you're on mute.
You're on mute, Dr. Suryanarayan.
Thanks. I think why change for a reason? If something is working well in your hands, I don't think you should change, whether it is anterior, lateral, or posterior, except probably for extreme situations. The 6% incidence of dislocation posterior are all historical data. I think if you use all the modern precautions which have been advocated and prophesized, do it right, get your hip right, I don't think there's any big difference between the posterior and anterior. Most important of all, I think, is the degree of extensibility on the posterior side. For any reason, whether it's primary or revision, you need to go extensile. Not that the anterior doesn't allow you to be extensile, but I think this is a far more versatile. So I think it's a matter of familiarity, how we are baptized with. And all of us, I think, probably have veered towards the posterior, happy with it for almost a quarter of a century. So why change for that?
Yeah. So Krishna, what do you think? I mean, the direct anterior approach, is it becoming more of a marketing thing, or is it really beneficial? Would you consider changing to a direct anterior approach? What are your feelings about it?
Yeah, I think the jury is still out. We don't know. I have done a few direct anterior approaches. I don't see any difference between direct anterior and posterior as after next week or so. Definitely have walk without speaker. That's my observation. But I don't think there is any evidence to suggest that we should switch approaches. I would completely agree with Dr. Harish and Suri sir that we should not switch approaches. And I would also agree with you that in America, it's a big thing. Patient is driving the advertisement. So they ask for it. So they come and ask for a direct anterior approach. So it's a good tool to have in a surgeon's armamentarium, but I don't think it is there to replace the posterior.
Yeah. Okay.
Can I add one more point, Mahesh? At the same time, I think as physicians and surgeons, we have to not shut our eyes to anything. I think if you see the European experience, I mean, direct anterior is not come out of the blue. It's been there for a long time. I mean, most of them, if you see even the French surgeons in the 90s whom I had observed, they'll be standing and then taking a small anterior and then literally putting everything anterior. 2 points probably that will still be open is we are talking and harping only on dislocations, but with regard to function, with regard to speed of recovery, and with regard to accommodating the modern demands, daycare sort of a procedure. Do it or don't do it is a different story. But whether these things are veering towards and making or facilitating those approachable possibilities is the point that is open. And I think we should keep our eyes open. Though, of course, like Krishna says, the jury is still very much open. I think we should not push it, but then logically analyze, try probably in the smaller cases. See, sometimes also the other thing, I was other day watching Soul do the super path. I mean, you are now compelled to bring in imaging, you're trying to bring in more complexities to the procedure, which can be done without. So that's another factor that weighs whether you should or should not consider, given our own limited circumstances, our own constraints. Some things are possible in some societies, some things may not be.
Yeah. Suri, in direct enter approach, I had a debate once in the last 1 year. And the person who was propagating it, there is a 15 to 18% incidence of a injury to the lateral cutaneous nerve of thigh, which is very high. Nobody talks about it, and it is also in the published literature. And it is very uncomfortable for a patient to feel numb. They say many of them improve over 1 year, but you talk about sending patient home the same or the next day with a numb thigh on the one side in 1 out of every 5 patients. I don't think it's an acceptable thing for us.
No, precisely that's what I'm saying, Harish. Just keep our eyes open and see what's happening around. Not to jump into it, not to make a big deal out of it as if that is the new kid on the block. But probably, I think, things all do get refined over a period of time. Maybe I think not everybody who is doing it. So let's keep it open and see for a while. Because if you outright try to reject, probably we may be missing and losing some things over maybe another next 5 to 7 years. Then it will be a standard of care. You never know how it goes.
Okay. Sanchit, any concluding remarks?
No, I agree with all the points made. I think that's where the attraction for that spare approach is coming in, because it's actually just a variation on the posterior approach. So things that we are familiar with, and it doesn't need massive amounts of new kit or new table or something like that. Just better retractors, and then you're there.
True.
Yeah.
So
I think we lost Sanchit.
Can you hear?
Can you hear us?
I think I lost connection for a minute.
Yeah,
can you hear me
same
now?
happened here. So yeah, I can hear you now.
Yeah, no, so that's what I was saying. I think the spare approach, it may gain popularity in the future, but that it depends a bit on what you're thinking about the sort of entire quadriceps cox structure is.
Yeah. Okay.
But the whole enhanced recovery stuff is almost the workup around, and education and physiotherapy seems to be driving it.
Yeah. Thanks. Sahil, can you hear us?
Yes, sir.
Yeah, so I'm going to thank Sanchit and then request Sahil to present the next video, which has been sent to him by Dr. Vijay Bose about reaming techniques of the acetabulum. So can you go ahead, please, Sahil, and share your screen?
So unfortunately, Dr. Vijay Bose couldn't make it. So before I share his talk, Suri sir, would you like to finish your presentation before that?
Okay.
Since you had some time commitments as well, we could take your presentation.
Yeah.
Before, and then we can move to Dr.
Perfect.
So.
Am I visible?
Yes.
So I think I'm keeping this very simple, and thanks Mahesh, thanks Sahil for this invite. I think it is always a pleasure to be, and at this time we see everybody only virtually more or less, so at least some few words with faces seen. Thanks indeed for the same. I think the going is great. My contribution here is for about the dual mobility. I mean, it's truly not the new kid on the block, but something we are talking more often these days, and I'll keep it very simple. What actually is the concept? I think this is a concept that was born out of France. Professor Gilles Bousquet and André Rambert was the engineer. And this goes back way back in the 70s. The French called it the dual mobility. The British preferred to call it the tripolar cup. So both of them probably signify the same. So what is dual mobility? Basically, to all the beginning surgeons and others, this is basically two concentric articulations. We have a large diameter polyethylene articulates with a smoothly polished acetate cup, which is totally unconstrained, like your unconstrained bipolar or unconstrained Austin Moore, whatever. And inner to that, you have another liner, which is basically a small metal or a ceramic head, which articulates with the inner aspect of the polyethylene. But this is constrained. This liner is constrained. So you have a combination of a constrained and unconstrained liner. It is, to put it simple, we can probably say that it's basically an impingement device. When I say impingement device, is basically that when you have the neck moving up and the whole movement, primary movement occurs in the inner one, which is maybe a 22 or a 28 head. And then when the movement there is exhausted and the neck starts hitting the outer cup, then the outer cup starts moving. So the outer large head poly rotates only after the contact with the stem. So you get that additional percentage of movement within that till, of course, it impinges over the metal, which is catastrophic. So basically, dual mobility functions as a large femoral head. And we have all the benefits of the bipolar or hemi-arthroplasty with the negation of all the deficiencies. The jump height increases. For example, if you see the upper picture, conventional, the moment the hip neck hits the base or the base of the inner poly or whatever the articulation is, ceramic, whatever, it starts impinging, the whole thing starts toggling. The head will start levering out of the socket. This is the jump height or the jump distance. The larger the head, the larger is the distance. That's how the range of movement increases basically. However, in the dual mobility, what happens is the neck hits the poly, but then it continues on for some more range till it comes to the point where it is in contact with the metallic basic, the primary cup. So this increased jump distance helps you probably also to avoid any sort of a jump out for a little longer range, prevent the tendency to dislocation subsequently. So the cup is stable, avoiding stresses on the bone interface at the upper end. So in the fully constrained system, what happens basically is that you have a lot of constraint that comes in, and this is what is relieved by the dual mobility. So that's the basic difference between the constraint capture and this set. So we all need to address three questions. What problem are we trying to solve by doing this? Basically, instability, or address the smaller instabilities and dislocation, especially in the at-risk group. In the previous discussion which I was listening to, basically, the speakers did mention about some areas like where you would not use a ceramic on ceramic, altered anatomy, altered modification, dysplasias, where you need to probably adjust the cups, and for some reason you may not get it spot on. So to protect that at-risk group, I think this dual mobility is a great boon. It helps subsequently. So what forms the at-risk group for instability or dislocation? We know it well. Subtle malpositions in the revisions where there's bone loss, where you're reconstructing the columns, pillars, dysplasias, cognitive dysfunction, patient doesn't know they go through the extremes of movement, or neuromuscular issues where you don't have the support of the muscular tone. There has been some discussion about whether elderly fall into this or the high BMIs, but the jury is still not out. It is not very, very clear. The new aspect which we discussed essentially is the fixed lumbosacral junctions. I think these are another group which we need to look at and probably may warrant a need for this. Remember, incidents following multiple procedures almost go to 10 to 28%. There may be subtle instabilities for many reasons. This was the data in 2011, but I'm afraid at this time, as we see the failures, it probably works out at the same level. So nothing much has changed in the last decade. I bring this point because subtle implant malposition is sometimes we fail to recognize, and that is a potential possibilities. If you exactly take the AP view and a good lateral view to assess what you are on the terms of anteversion and inclination for that given case, I think if it is not, we miss a lot of points, and that could be catastrophic at some points. Minor ones which recognized on the table are controlled with the simple options like the elevated rim, socket wall additions, and various other techniques, which is possible. And when you have the elevated rims, you can rotate it to the way you want, to the angle you want, and then protect it. But major ones will almost always end up with a revision in this case. So impingement, often we also find towards a penetrative impingement over a period of time. This is just a simple example. Here you have at the point the neck irritated, but the moment the neck starts penetrating, the head penetrates inside deep in, you find these bubbles in the hollow gap. And this is not hitting much earlier. And the late dislocations that patients present with, especially with the small heads or the worn out polys, when they get up from the sitting position, they dislocate. This is one. So in short, what I was trying to say was whether whatever be the reason, invariably in lot of situations, it is a terminal mechanism in many situations for a dislocation. And this is what you would like to avoid by increasing the arc of rotation in a safe zone. This is also certainly important in the small women and the small anatomies we treat quite often, and very small acetabular cup sizes and dysplasias. Another red flag area where one should be very exacting in terms of your combined anteversion, in terms of the cup inclination, offsets, everything. The smaller the offset is the danger like this. And that's where the smallness of the patient or the patient profile comes into view. So then in that case, since there are other issues with which we have been dealing for over 2 to 3 decades and for many years, what are the issues with the current options? Like often the reasons for dislocation are basically very many. They are a combination of it. And we are trying to solve this by improving the jump distance by using the maximum large head possible, using a combination of the cross polyethylenes available to us today. Length offset restoration with the modularity which is possible on the femoral side, robust tissue closure if you are a posterior exposure person, or probably try anterior and get the alignments right. And most of these options we use are the elevated liners, lip liners. Sometimes when you use elevated liners, it could itself be a problem because if we don't rotate it right, that could impinge much earlier in external rotation if you have rotated it more posterior. So be aware of it, be careful of it, how you dial in the offsets. Lateralis liners, high offset stems are available today to control the offset and control the tissue tension and the abductor tension. Of course, there is the other one today, if you are a robot assisted, which you're going to see later on the last presentation, others talking about it. Robot or navigation, I think, are other ways where to make your fixations more precise. And in fraud, nothing else works. And if you are failing or if it's a failed situation, we have been using the constrained liners. Recurrent instability in the patients with poor bone or inadequate abductor tension, especially with multiple surgeries, is a serious problem. This remains a challenge in the difficult primaries, in the multiply operated situations, post-trauma, or even in the complex primary cases. So in this, always demand some form of additional augmented system constraints besides all the strategies we employ conventionally in terms of the alignment, the head, the tissue closures, and all the other possibilities, and sort of contract the capsular free space inside this. Various types of constraint liners have been available, unipolar liners, bipolar liners, and many other possibilities were there. The designs varied with sort of cutout inferiorly to avoid impingement and many other design options. But if the simple fact of the whole thing is that amount of stress it puts on the interface. A disassembled head, when you want to assemble a constraint liner, the force required is less than 30 newtons. But a dislocated, you need 2000 newtons. That amount of a constraint you have inside. With this constraint, the whole force, if there is an extreme movement, has to be transferred either to the bone implant interface or the cement implant interface right above. So I think this produces the interface stresses very high. This has been a big disadvantage in this case. And that's the reason always constraint liners had been advocated for a well-integrated non-cemented cup or the cemented sockets wherever possible and wherever available. So I think this was one sort of a little drawback which we felt always because there's a concern. Sometimes it might be a situation where you have to take out and totally revise it completely, in which case you don't have a cemented, well-integrated cemented, and you'll be compelled to go for a cemented. What are the failure rates? The more concerning issue was in various modes, failure rates seem to be quite higher in the medium term, 25 to 29% published across the line. And the failure sites were not also only one, which could be addressed to the bone shell interface, liner interfaces, bipolar femoral head interface, seen in tripolar, many other sort of designs were seen, and we had the various types of failures which are also discussed and devised. And these high failure rates reported has been a matter of serious concern, making everyone look at alternate options for this. On the other side, gluteal mobility, like we discussed, shown in the first slide, it is two articulations, one unconstrained, one constrained. The unconstrained takes over after the constrained has exhausted the range of movement. So it is a stabilizing option, unconstrained stabilizing option. It gives you all the benefits of a large head in terms of giving you an impingement-free range for a while longer beyond the normal. Better range of motion, impingement-free motion, and impingement-free dislocation. And the experience has not been small, though the discussion in the common world has been only for the last about 10 to 15 years. I think this has been in the French data from 1980. So I think the number of years it's been in and the published literature is quite long. But one caveat I would want to add to all the my colleague orthopedic surgeons down is the rules of the game for socket alignment stay the same. There's always a concern, some kind of a laxity. If there is a little vertical, it's okay. We'll use a mobile dual mobility. We will get away with the problem. Or you're not as much anti-verted. We can accept a neutral version. No, I think one should not compromise on the acetabular alignment position, which you will be seeing in the next video, how to get it right. And we have to follow the rules of the game. Please do not change it. We can get the added advantage of the dual mobility by sticking to rules. Reported outcomes, most of these in the earlier on, I'm taking this because these were the long-term revision, primary and the revision data. The survivals has been pretty much good and spectacular. In fact, the dual mobility started for use for the primary situations with some sort of a risk element involved. But over a period of time, I think there were more number of primaries being performed, but the results have been pretty much good. None of the procedures, none of the materials, prosthetics have been without any concerns. And three major concerns one should be aware of when you're talking of dual mobility is wear, acetabular loosening, and intraprosthetic dislocation. These three were the concerns which have been discussed extensively earlier on and to some extent even now. But things have changed in the last 2 decades, I think 10 to 15 years, with the onset in the advent and the use of the cross-linked polyethylenes and the designs of the sort of dual mobility pictures. Where accelerated wear was a potential concern. Basically, the initial thinking was, if since there are two articulations, both on the outer side of the poly and on the inner side of the poly, there could be probably more wear-related debris and subsequent loosening of the acetabular cup. But the literature does not seem to be supporting that much this sort of a concern, and there is not much evidence to project so far as this concern is concerned. Having said that, if you look at the current designs, the highly cross-linked polyethylene, which we use now as the interface material versus the conventional poly used in the earlier literature, there is a 97% reduction in the wear, and this is a published data. So I think that concern is slightly mitigated if all the other things being correct. If poly alone is the source being looked into, I think that has been mitigated considerably with the use of cross polyethylene. That's a good sign for us to be probably a little more emboldened to use this. Cup loosening, again, if there is not much of a poly debris and if it's a well-integrated cup, there is no need of a concern. Again, the earlier cups were porous coated first generation, poorly coated, poorly designed, but a lot has flown under the bridge in terms of the design, surface manufacture, the highly integrating porous surfaces available to us today, reliable fit, initially all the hemispherical fit and design. The coatings are better. Another point was previously none of the cups could be used with a screw. They were just screw on. If you don't get your primary fixation correct, they would loosen up. But today we have got the possibility to add screws. So there is a lot of protection that has come up over the last decade in terms of the reliability to use the dual mobility sockets more predictably with better integration. This is one point which is still probably being discussed and debated, the intraprosthetic dislocation. What is intraprosthetic dislocation? Basically, it is loss of the polyethylene retentive rim. When you're press fitting inside, when there is a retentive polyethylene, because it is over the hemisphere sort of a poly, which is supporting beyond the equator, the head that is inside. If the peripheral margin is gone, then the head is free for all to sublux out. So there is eccentric wear, which can be triggered by many reasons. It may, for example, if it's a vertically placed socket, it could be a very highly valgus situation, or the stem design, which can sort of erode the superior anterior part of it. Then the head starts migrating superiorly inside, and this can subsequently, over a period of time, take off the retention and then come out. That's the reason the incidence varied. The older designs, it was almost about 5% at 17-8 follow-up. Basically, again, because of the poly quality, because of the design as well. These had been looked into subsequent to the failures, and the current data, if you say, it is hardly 0 to 2.4%. So long as I'll come to the point what is additionally changed in this. So current data, again, sort of has been doing some work in regard to minimizing the intraprosthetic dislocations. So this is the older data. Again, if you find roughly going about 2 to 5%, that keeps changing based upon the different designs. And all these published reports, again, are not with a single design. There are multiple designs, which we are not, most of us are not familiar with, most of continental Europe, predominantly French. When you have intraprosthetic dislocation, when you have this, I think this is like a picture of ours. Very recently, we found this one to our shock. This is a dual mobility done. What happens, like I said, if the alignment things move, or if there is something wrong, or the cup is very much valgoid, the repetitive impingement of the neck on the polyethylene rim superiorly leads to progressive wear in the capture, and eventually the femoral head escapes. This is what typically is called as a bubble spine. You will find a black air mark pocket like on the inferior side, basically the poly debris and the debris reaction, which we find in the failed revisions, aseptic failures in the revisions. So this could well be one of the reasons, could be that. So this is the mechanism by which the intraprosthetic dislocation fails. So what do we do? I think if you see the newer reports, it also seems to support the head size, that increasing the head-neck ratio by using a 28 head with a standard neck dimension, I think the failures have decreased. So I think the head-neck ratio seems to play a big part in this. Use of cross-link poly, again, reduced the contact wear, so probably it will help us. And the most important third thing change that has happened is most constrained captors, unlike the bipolar, you can't push it with your thumbs. I think you need a back table to press it down and push it in. So that is the element of increased peripheral retention which is being given to this. So this design change, like, the constrained capture of the head to the poly with the back table pressure is a good addition, keeps it really constrained. And if the polyethylene quality can support it, probably we will minimize this incidence. So where are we now with regard to use of dual mobility and constrained liners? I think most important indication, as I would see, is in abductor deficiency and revisions, neuromuscular issues in primary situations, multiply divided revisions and surgeries where we find that because of the bone loss, your cup size is larger, and then you cannot use more than 36. I think dual mobility is a good solution to this. Very short, stocky stature, Cox or Vara, sometimes with a small socket, maybe a consideration. But overall, if you look at it, indications probably is around 10%, 10 less than 10%, or maybe if you stretch it long to around 10%. But there are concerns that still exist, and all like what we discussed before, we should be careful about it, how we nuance the use of dual mobility. In revisions, like I said, I think it is potentially a great advantage, large head neck ratio. And a lot of times where abductor tissue rotators are suspect because they are partially scarred, because they're partially shredded and more fibrotic, which cannot support like your conventional muscles. Subtle malpositions is inevitable. All of us are humans. We will make some mistakes. We will not be exactly spot on. So I think this will probably help us to overcome this, but make all attempts to get your position as correct as possible. Potential soft and hard impingements. And then when you take it to the range of moments, unless you put your finger in between the areas where we look at, between the posteriorly and superiorly, between the trochanteric tip and the superior acetabulum, thick capsules sometimes could also be a reason for a lift-off and the dislocation. So these areas, I think this is a protective, augmented protection, as I say. Short to midterm studies, I think outcomes are excellent with low rates of dislocation. This has been published data. There are a lot of publications, again, in the revisions, THA in revisions. I think the results are good. So I think it is one back table option, which is very useful, and we must keep it. Should we use the primary? I think in the primary situations, there are no defined indications. I think we need to exercise our judgment and our wisdom in terms of should we not. Ideal, like we have discussed before, is the high-risk category of any sort. Primary, it may be a dysplasia, trauma, post-trauma, whatever. But my concern often comes is that sometimes you hear this talk about using dual mobility for a better range of motion. I think is a question mark we could put. I think this is open to discussion. I think all of us may have different take on this. And to offset the technical faults, like I mentioned, I think that will be seriously an issue which we should not allow. Though well done in the correct situations, used for high-risk cases, the results are as good as the primary. So I think dual mobility does work very well in these cases. So if you look at even the current publications, if you look at the results have been across 95 to 98% published across. So in the high-risk patients, I think it's a great indication. I think one cannot discount it. Just a couple of examples to round up this talk. This is a neck of femur, 8 weeks old, residual poliomyelitic limb, practicing surgeon. The power is borderline. Certainly, I think dual mobility. These are not very high demand patients. They are prone to probably a pelvic tilt, pelvic rotations. I think a great option to use a dual mobility in this case. Second case is a fixed pelvic situation, small size. There is always impingement concerns. Ankylosing spondylitis, spine stabilized. Even though the alpha express S1 segment is non-instrumented, it is fused. So I think dual mobility in these cases, again, is probably justified when it's using. So nuance your indication wherever it is necessary. Or these sort of major tumor resections, and this was a major resection, what you have done, just get a trabecular cup, then you cement in a liner, and then use a dual mobility. Basically, that helps you because abductor is very much in question in these cases. So I think in conclusion, I think dual mobility has a place to stay. We need to nuance it. It is not free for all. There are concerns, and there are concerns with certain indications. How much to use in the primary, it still is an open question. I think we can discuss with the comments from all the other experts in the panel. Thank you.
Thanks, Dr. Suri, for that excellent talk. I have a couple of questions. I'll wait for the other panelists to come up with their questions as well. Again, like a direct anterior approach, I think there are more patients who are walking into my clinic now, demanding to have a dual mobility cup in younger patients when there's actually no indication to put it in. I'm reluctant for two reasons. One is because you're adding another interface of a titanium cup and a cobalt chromium liner, which is going to create some problems like we had on the femoral side. So how do you counsel these patients, or would you just do a dual mobility in these patients?
No, I don't. I take your point. I do not. I try to discuss probably if you can get a 36 SA, that is enough for you. But fortunately, we have not found so many of them coming, but some of them do this Google search and then they come back expecting range. I said done right, even the standard hips with a regular thing can give you the fair amount of motion what you are aiming at. And then the current polyethylene liners and the cross polyethylenes have probably stood up very well even for a little higher demand. So I try to pull away unless I find a reason. I think they should not find the reason. Yeah. At least in our setups, yeah, certainly.
What do you think, Krishna Kiran? What is your answer for such a situation in a youngish patient? Would you prefer to put a dual mobility in a younger patient, one, because they demand it, or they say that they want to sit cross-legged? These are the patients who are now coming up, reading on internet, or somebody is telling them that I'll make you sit after a hip replacement. So what do you think? What do you suggest?
No, I would not do a dual mobility unless I find some high risk factor for instability in that particular patient pre-op. So I would use it all the time if I'm doing a THR for a neck femur or a failed IT fracture in an elderly patient, so low threshold. If I'm using a cage for some reason, I will always cement a dual mobility nowadays. Or I'm doing a chronic pelvic discontinuity with a TMRS, then as Suri sir showed, we normally cement a dual mobility. And if it's a young patient, but is got multiply operated for some reason, maybe a failed hip which was operated, infection, and then is undergone multiple surgeries, then I have no reservation in putting a dual mobility. So we've been doing it for a while now. But your point is well taken. Additional modular interface with the potential for metal ion release is a concern in the longer term in the young patient.
Yeah. Adarsh, anything different that you want to add? Welcome Adarsh as well on the panel.
Thank you, sir.
I think he's been with us for a while.
Yes, sir. Yes, sir. As you said, there are a few people who are asking. Just last week, a young patient came and asked. Actually, they're not even that educated. I would say moderately educated person came and asked about it. So there is a lot of stuff going on the internet. But as Krishna sir said, and as Suri sir said, we have to probably tell them that it's not indicated right now. You're probably spending more money for no reason. I mean, that definitely pushes them off. So,
I think this, can I just add one? I think we need more counseling to these patients. No, like yes, we say, the knee, high flexion knee is the classical example.
Yeah, exactly.
And I used to tell them that I do the same thing both sides. And no, some get it right, some can sit cross-legged, some don't. There are many other issues that are involved with it. So whether I do the dual mobility or not, if you want to sit cross-legged, I think nobody can guarantee of this. Just because I put a dual mobility, you're going to sit cross-legged. That is point number one. And there needs to be a long view on this. Not the immediate functional outcomes, but it is a long-term survival. And it becomes more critical the younger the patient. So like Krishna said, unless there is a red flag for you for some reason, revisions is a totally different ballgame. You can be much more extended in your indications, certainly. But in the primary, certainly, I think there is a concern. I think we don't have the last word yet.
Yeah, thank you. Harish, do you want to add anything before we move on
No, I agree with Suri. There is no question of using dual mobility in a people who are less than 50 unless there is a medical or mechanical issue. Such patient, I generally tell them that among you and me, I am the expert. Let me decide what you need best. Because many times they have come, as you rightly said, on the internet, Google network. But if you explain them properly, if you educate them properly, they always accept what you tell them. So there is no question of, acceding to their demand and doing it in a younger patient when you don't believe it.
Okay. Yeah. Thank you. Sahil, how do you want to go? Do you want to finish Dr. Bose's talk first and then request others to complete?
Yeah, if you don't mind, others, can we complete?
Definitely. I think we should learn. I mean, we should show the reaming techniques first, and then we can head over to the robotics part.
Okay. So as I mentioned, Dr. Vijay Bose couldn't make it due to some last minute commitments. So he has recorded his lecture and sent it to us. So I'll just share my screen. Is it visible?
Yes, it is.
Yes,
visible.
we can see it. Yeah.
Good evening. Firstly, my thanks to Mahesh and Sahil for inviting me for this program. It's always a great pleasure and honor for me to be part of Maharashtra Orthopedic Association proceedings, and greetings from Chennai. So my topic today is Acetabular cup reaming technique and cup positioning. So I understand that this is meant for primary hip arthroplasty, and so I'll stick to very much basics. The first question one should ask is, why should one ream the bone in a non-synthetic socket? Now, when I ask this question to trainees and fellows who come, the invariable answer is they say to expose the cancellous bone. Now, exposing this cancellous bone is of course important because simulated socket will vegetation of the cement with the bone. However, for non-synthetic sockets, the reason to ream is not to expose the cancellous bone. Then why should you ream? There are three reasons.
The talk is not advancing, Sahil.
Yeah, just one second.
However, for non-synthetic sockets, the reason to ream is not to expose the cancellous bone. Then why should you ream? There are three reasons for it. First is that
I think there's some issue. I'll just work on it. I think till then we can start with Adarsh's talk.
Yeah, is Adarsh ready?
Yeah, I'm ready, Doc. Yeah.
Yeah, I think nothing has excited me more in the last 1 year than watching Mako robotic hip replacement. So let me see what Adarsh thinks now. We've interacted briefly once about it. So let's hear from him again about robotics in total hip.
Thank you. I just want to see. Can you see my slides?
Yeah.
Yeah. So thank you, everyone. Good evening. Thank you so much, Dr. Kulkarni and Dr. Sahil.
Yeah, we can see it now.
Yeah. So thank you, Dr. Sahil and Dr. Kulkarni, sir, for inviting me and MOA. So today I'll be speaking on the Mako robotic total hip replacement and briefly about the surgical steps as well. So I know a lot of the people on the panel have also heard this talk before because we spoke about it just a couple of weeks back as well. So please forgive that. So total hip arthroplasty is one of the most successful procedures in orthopedics. We know that, and it's evolved significantly since Sir John Chanley's low friction arthroplasty. And the advantages have been all over in terms of implant design, material science, coupling options of the bearings like metal and ceramics. But the latest advancement has been in robotics. So there are so many variables in a hip replacement. Yes, it is a very good surgery. You get the forgotten joint scores are very, very high, and the patients usually have very good outcomes. But there are so many variables which actually come into play. There's the cup size, the femur size, the cup height, the depth, the center of rotation, the anteversion and the inclination, and of course the offset, the limb length discrepancy, and the bone stock as well. So what if you can accurately address all of these at once? right? So that's what the robot helps us to do. So we'll be talking about the Mako, the Striker Mako robot. And this robot helps us to take care of all these different variables in one go. So I'm going to play this brief video just to show you the steps. Let me know if this video is very clear. If it's not, then I'll play the original file. Okay, I'm going to start the video. So the first thing is we get the preoperative CT scan. I hope you can see this animation. Okay, so the pre-op CT scan gives us a nice reconstruction of the hip. Okay, and you have the patient-specific planning. So this is the enhanced workflow where you also do the femur. There are multiple checkpoints on the femur, which you have to mark. It gives you the accurate femoral neck resection point. I hope you can see the video, everyone.
Yeah, we can see.
Okay, yeah, thank you. Right, so you can get the accurate femoral neck resection point. And then, of course, it also helps to tell us what is the version of the neck, of the stem that we put in. Once you put in the size that you have already pre-planned, you can just put in your arrays and see whether your anti-version is decent or not. And then you head over to the acetabular. You have multiple points again here, around 40 points that you have to mark to reconstruct in real time what has been put in by the CT scan. And you get this nice virtual cup over there. Boundaries to help make sure that you don't stray out of line and do your single ream, and you just ream out that green part of the bone that is required. It's a single ream, as I mentioned. And finally, it also assists in the impaction of the cup. So the robot is helping in multiple steps. It's not just the reaming part. You're doing the pre-operative planning. You're doing the reconstruction. You're planning what the size is going to be and your positioning of your cup. It's also helping you in the reaming itself. And finally, even in the impaction, it lets us know how much further deep you have to go when you're impacting your cup. Okay, so this is just a brief animation. So this is the OT layout. So I'll be talking about the posterolateral approach, and the robot is usually, it's present on the opposite side. It can be on the same side as well. We have done a few cases of bilateral hip, and we managed to do it without shifting the robot around too much. Okay, so of course, after finishing one side, doing the preparation for the opposite side again in the lateral position. Okay, just a brief workflow. So the planning is the first part. After that, you have to do the landmark placement. You have to throw the robot where exactly is the greater trochanter, where is the acetabulum. You put in your pelvic arrays into the iliac crest, and then you start verifying your checkpoints. The acetabular registration is the most important part, where you have to let the robot know which is superior, which is posterior, so it has its proper orientation. After that, it's going to help you in the reaming and the cup impaction. The femoral preparation is done manually. This is not done by the robot itself, but it does help to tell us which size that we're going to get, something like your templating. And then you have the trial reduction. And after your trial reduction, it'll give you your reduction results and tell you whether your pre-operative plan is actually matching to what you have implanted. Okay, so if you go in a little bit of depth about each part, first is the implant planning. So what are the different parts that you can plan? As I mentioned, we're taking a CT scan beforehand, and the first thing we check is about the acetabulum. You know about the position of the acetabulum. You know about, you can see the transverse view, the coronal view, and the sagittal view. You know where is the perfect bone stock, the center of rotation, and everything is planned beforehand. You can even decide your inclination, your version. And it's also going to tell us what is your pre-operative limb length discrepancy and what are you planning. You're planning to get obviously equal to the opposite hip. And that you can play around with just by changing your different kinds of cups and your different kinds of stems. Okay. It also helps you to plan about the stem size, what is the perfect scratch fit, and it's going to give you a pre-op visualization of the post-op X-ray. This is all about the implant planning. So we know that templating is very, very important in hip replacement surgery, but here we're going one up because we're moving from a 2D manual planning to a 3D model-based planning. So instead of taking a 2D reconstruction of a 3D joint, we actually have the 3D joint in front of us. Okay, I'll just give an example of this fairly simple, straightforward right hip replacement, just to show what are the different steps that we have to go through. So first thing is you get a 3D reconstruction, as I mentioned, and you know the pre-op limb assessment immediately. So I know that my hip is 3 millimeters shorter than the opposite side. Okay, so I know that whatever implants I put in, I'm going to try to get rid of that 3 millimeters of shortening. Okay, so this is my the planning of my implants. So with a 44 cup, a 32 head, and a stem size of 2 and neck angle of 127, I managed to bring my limb length to equal to the opposite side. So this is just like a templating. Then the acetabular component placement is a very important part. It's the part which I love the most. You can actually see all the 3 different planes, the transverse, sagittal, and the coronal. It's going to let you know what is the perfect bone stock where you're going to get your perfect press fit. And you can also decide your cup inclination and inversion right here. You have a 3D construction of the same thing. You can just rotate your view to see how your cup is looking. This is just a rotated view showing us a nicely fitting acetabulum. And this is, of course, after determining 40 degrees of inclination and 20 degrees of version. It's also helping us to restore our center of rotation. If I feel that my rotation, I want to go a little more medial, or if I want to go a little more lateral, superior, inferior, that's all up to us. The pink is the preoperative center of rotation, and the green is the middle of the cup that we are going to place. Okay, this is just a rotated view of the same thing. Then, as I mentioned, the femoral component sizing and offset adjustment can also be done. You can see what is the perfect scratch fit. This particular case, it showed us that the size 2 stem is probably the right stem to be using. And it also lets us know what are the different effects of the different stem neck angles. They have a 132 degrees and a 127 degrees neck. So if I got a 127 degrees, it gave me an equal hip length. So I'm pretty happy with that. Right? And as I said earlier, it gives us a pre-op visualization of the post-op X-ray. And most of the time, we're able to completely recreate this particular picture. So we spoke about the planning, the landmark placement, I mentioned the pelvic array placement. Now we're going to speak about the verification of the checkpoints. Okay. So you first have an initial registration where you just have 3 dots, 3 big bubbles that you have to try to mark. This has to be very exact. Okay. This model is going to be recreating what CT scan you have entered into the robot. So you have to be very spot on to tell the robot exactly where is posterior, where is anterior, and where is superior. So it has a proper orientation. Then the fine registration, you have 40 points all over the acetabulum and outside the acetabulum. You don't have to be exact over here, but you have to make sure that you're reaching the right depth of the bone. That's important. Okay. And you should be within that particular ballpark, right? Again, as I mentioned, this is just to feed to the robot what the real-time bone is compared to what CT scan data has been entered. So then we go on to the reaming. As I mentioned earlier, it's a single ream. The ream is not, it does not lock in the robotic arm. So this is still done by us. It will show us where is the green part of the bone, which is the bone has to be reamed out. If it's more superior, you push it more superior. If you feel it's more posterior, you push it posterior. This is not determined by the robot, but it lets us know where to ream. So just a small video to show how it works. So as I mentioned, the robot is not doing the procedure. We are still doing the procedure. The robotic arm is attached to the reamer. Please let me know if you can see this video again. So that's me, the surgeon, and the robotic arm is getting brought into the plane. Okay, and
Just start playing now.
Okay.
Not very clear video though.
I think I'll just, if you don't mind, I'll play the video from the file so that you can actually see what.
Yeah, much better.
Yeah, thank you.
Yeah.
Okay, so this is the first video. So the robotic arm is coming into the plane.
So the screen hasn't come in view, the other screen.
Oh, okay. I'm sorry.
Now we can see the blank screen, but.
Is this better, sir?
Yeah. Yeah, now start playing. Yeah.
Yeah. Okay, so you got the robotic arm within the field, and I'll play this second video. So you first tell the robot where the robotic arm is, and this is the green part of the bone. This is the
not very clear, unfortunately, Adarsh.
Oh, I'm sorry. This is a
Something
glitch with Zoom every time. Yeah, every time.
It's unfortunate, but
yeah, I wish there was a better way to do this.
Now it's playing well in the slideshow. I think it is playing well now.
Okay, okay, good.
Yeah.
So could you see that? Yeah. So
we
you
can see
reamed
the
away
green
the. Yes. Okay, you could see the green getting reamed out, right, sir?
Yeah, yeah.
Yeah. So it tells us where to ream, and it also tells us how deep to go. And
Yeah, try playing like this.
I'll try it once more. Okay, so can you see that, sir, now? The green part of the bone?
Yeah. Yeah, yeah, yeah.
Yeah. So then the reamer has come in. As I said, the robot is not locked in. We are still directing it, but we're directing in the direction of the green part, which is showing to us on the screen. And it's also telling us how much more medial to go, how much more superior to go. And we have to try to aim to get zeros all over there. Okay, so that's a single ream. As I mentioned, sequential reaming was always required in manual THR with incremental reaming followed by trialing. Here is a single ream. We know how much to ream, so we don't have to keep on trialing there. Right. So let's go on to the next part. The next part is the cup impaction. So here we don't even have to worry about trialing. We go directly to our final cup impaction. Here is where the robot actually locks in. Once you've done your ream and you've decided your cup size is going to be here, it's 56, and you put your cup on that particular robotic arm, bring it near the field, and you lock it. It directly automatically moves into the position that we had determined. We determined 40 degrees and 20 degrees. It goes into that position, and then you start hammering. After hammering, it's also going to tell us how proud we are. Every time you hammer, you re-record, it tells you are 8 proud. You hit it again. It tells you you're 5 proud, hit it again. So it comes down to 1 proud. So it's going to tell you how much more to hit as well. So let's see if you can see this video. Hopefully you can.
Yeah, we can see.
So that's perfect. So that's the real-time cup going there. Okay, so now I've locked it in. If you can see these green numbers over here, it's locked into what we had planned beforehand. And in the screen in the bottom right is the real time. I'm hitting it, and you can see the proudness over there. It's on 8. Now re-recorded, it's come down to 2. One more shot. And re-record, it's telling us 1. So we usually try to aim for a 1 proud. We don't go much deeper than that, and we get a perfect fit over there. Okay. Finally, you're going to check whether what you had planned beforehand is actually matching to your final cup. So you take 5, sorry. Yeah. Okay. So you take 5 points on
Sorry, yeah, the next video, I think, Adarsh.
Yeah, I'm just trying to go to the next slide. It's hanging. Oops, okay. Sorry about the glitch. I'll quickly just skip to that same slide again. Yeah. Okay. So we come to the next part of the process. After the reaming and the cup impaction is done, we go to our trialing, right? And now we know what are the reduction results. Once we've reduced our final cup and we put in our stem, we know whether it's actually matching what we had planned beforehand. The plan was 40-20, we got 40-20. The combined version, it tells us, and it's also telling us how much length we got compared to the opposite side and compared to the preoperative side as well. So as I was mentioning earlier, you take 5 points on the cup that we had impacted, and it's going to tell us whether we have matched what we wanted. So we planned 40-20, we got 39-22 in that particular case. I'm just showing you an example of how that's done. So as I said earlier, we already know what the X-rays are going to look like. This is the pre-op X-ray, 3D reconstruction, pre-op visualization of the post-op X-ray, and our cup sits exactly identical to what we had planned beforehand. So look at the cup exactly where we had planned it. Okay, what about the procedure time? We're going to put in the arrays. We have time taken for doing the registration, So yes, you may think that the operative time has increased, but we have found that the operating time is almost the same because the reaming and cup impaction and the trialing, that has completely significantly reduced, hardly doing 2 minutes and 3 minutes for each of them. So our operative time has become equal and sometimes a little even faster than manual. So what does all of this mean for the patient? Oh, yes, it's definitely giving us a lot of comfort as surgeons, but it gives us reduced surgical time and blood loss, unparalleled accuracy in implant positioning, helps us to restore the limb length to pre-pathological state, smaller incisions and reduced tissue trauma, and there's a reduced trial and error and subjective feel. Future, there are new software coming up which is going to help us recognize and manage hip impingement as well, and it helps to adjust for the abnormal spinopelvic anatomy, and also gives us an assessment of the combined version of the components. A quick example of 2 cases. We've done bilateral cases. This is a pre-op visualization of the post-op X-ray, just to show you how accurate we can get these. And we also use the robot for dysplastic hips. It tells us how the bone's going to look, where is the best bone stock, and we managed to get a very good version and inclination and good post-op X-rays as well. Just 3 studies I wanted to show to you. This is the study by Richard Illian, where he took 300 hips. The first 100 were the first 100 consecutive manual THRs he did. Then he took 100, the last 100 manual THRs he did before taking robotics. And then he took the first 100 robotic hip replacements that he did. And he found that definitely there is an improved acetabular component accuracy and reduced dislocation rates for his particular study. Then there's this studied a total of 20 patients. He took a pelvic and femoral bone models were printed. So after he planned preoperative with the robot, he made 3D models of the post-operative hip, and he tried to see how accurate these were. And he found that the acetabular inclination, the acetabular anteversion, the femoral anteversion, and the combined anteversion were all spot on. They were significantly accurate with the preoperative planning as well as the post-operative 3D models. Again, another study by Seth Cherubek, where he took 222 hips, which 113 were implanted with a robotic-assisted and 109 were manual. And he found that there was a shorter hospital stay, lower blood loss, a higher 6-week post-operative hip score, and a significantly lower post-op pain compared to manual cases. And this is his results that he published very recently, just a couple of years back. So, of course, total hip replacement does not need to be done by the robot. Definitely not. There are so many good results we have all these years, but it does help us. It does give us a lot of accuracy. And all these studies are showing that there is an improved accuracy in the liver neck safe zones. So it gives us a lot of comfort to do as surgeons. Thank you.
Thanks, Adarsh. Sahil, do you want to lead the discussion for this one?
Yeah, I think as he mentioned, the unparalleled accuracy in component positioning is the major advantage, I think, because many times we see our post-operative X-rays with the conventional techniques, and we feel, oh, you know, this cup should have had slightly less inclination, slightly more version, because what we are seeing intra-op is really just an eyeballing or a 3D visualization in our minds. But with the robotic precision that it offers is probably the game changer aspect in my mind.
Yeah, only K.H. Sanchit sir can recreate 3D in his mind. I think nobody else can.
What do you think, Harish? I mean, I have told you my feelings about it. I want to hear what Krishna.
I wanted to ask one question to others. How do you take care of the soft tissues in a robotic surgery? Because it will just tell you where you want to put the implant. But many times you find that there could be a tight structures either anteriorly or posteriorly, or abductors are too tight, and then you need to release them. Otherwise, you don't get good stability in the hip joint. Like sometimes you have a young patient, female, maybe TC fracture. You want to, put a hip, not a salvage by doing a fixation. And then these patients are very loose. And when you actually put an implant, which is templated, even whatever way you do the templating, you find it is too loose. You have to basically increase the either offset or a neck length based on the soft tissues. So how do you account for soft tissue? Because in your working protocol, there is no mention of getting a soft tissue balancing done anywhere or soft tissue laxity to be assessed. You are just mechanically putting cup in X position and stem in Y position,
Correct.
and then connecting them where there is no question about soft tissue. Like, I mean, there could be stiff patient who has previously undergone multiple surgeries with fibrosis around the hip joint. You
Yes,
may
sir.
need to do a lot of release, or you may have to actually on table use a smaller neck length or a smaller offset, because
Definitely,
tissues
sir.
won't just expand.
Yeah.
So how do you account
It
for
does
that?
not. It does not tell us, sir. It does not tell us what is the soft tissue. We have to still. That's what I'm saying. So we have to definitely have that knowledge and that set of skills to be able to change in the middle of the case. If you find that it's too tight, we can always change it. So we find that it's too tight, or if it's too loose, let's say it's too loose, we want to increase our offset. So we change it. We immediately on the plan itself, you can change your neck length, you can change your offset, and then we try to plan according to what soft tissue we have. So we don't have to go strictly as to what we have planned beforehand. It just gives us an idea. Most of the times when we don't have a soft tissue problem, it helps to guide us very well. But if we do have a soft tissue tightness or laxity, we have to use our clinical judgment, no doubt about it.
Krishna, what do you think?
So first of all, I must congratulate Adarsh for having the courage to embrace this sort of technology.
Thank you, sir. Thank you.
So it's a good thing. So I have done quite a few cases with navigation. It gives the same data as to what the robot gives, except that it doesn't do a single shot reaming, but it will give you data on the femoral component position, offset, leg length, everything. And it will also, you don't need to do a trial reduction. But we have to come to the facts first. First is that the robotic hips, which were introduced in 90s and these things, they had higher incidence of instability and heterotopic ossification, because of which they went out of vogue. So we don't know whether the modern robots will match up to what we already have with manual surgery. Second, the soft tissue balancing is not addressed adequately. So if you have a simple case with a AVN or something like that, you can create an impingement-free range of motion for that patient. But as Dr. Harish rightly pointed out, we cannot use it in complex situations. You can put your component well, but that is only maybe 15-20% of the game.
Correct,
it looks
yes,
very nice.
I agree,
The
sir.
whole thing looks nice because you spent a lot of time. Your interop time may be lesser, but you're doing a CT scan, you're sitting with it, you're planning. So it takes a lot of time. So what about the time which is taken later on? So that also needs to be factored in. How much time you spend for the whole patient, which is actually a good thing because the younger surgeons learn quite a bit from all these things. But currently,
it's like the time we spend on the templating, right, sir?
Absolutely. So,
yes.
There are pros and cons to it. Right now, I don't know how much it is cost effective, how much effective for difficult hips, but whether we like it or not, technology will be the way forward. So that is what is my opinion on it. So technology will be the way forward. With knees, I have found that with robotics, you can no longer say that this is all right. So it gives you the exact picture. So your fellow will point, sir, yeah, tight hai, yeah, kuch ye hai. So you can never say that. So it's a learning and humbling experience. So you have to use it, and you should be lucky enough to be able to use the technology to be able to, make any judgment on it. So that's my take. So I would welcome the technology. I hope it becomes better with soft tissue assessment and balancing in the future.
Sorry, Sahil, I just make a comment. I have seen the Mako 4.0. It is outstanding in the sense it answers some of the questions which are unanswered in my mind. Obviously, you said the navigation will allow you to get the leg length and offset right. Increasingly, patients are being very demanding about leg lengths. And that issue is nearly sorted with this robotics. Second issue, the spinopelvic calculations. The Mako 4.0 will calculate you exactly, considering the preoperative lateral spine X-ray and pelvic position, it will give you exactly the location for the cup placement inversion and the stem placement. So that was the second exciting thing. The third exciting thing I saw was it doesn't really add up to the intraoperative time. And it makes life much easier by putting the 3 points. And the one danger of the navigation system that I have seen were losing the reference points.
Yes.
With this new system, you don't lose the reference points. So halfway through the operation, you don't have to abandon it. So I think, obviously, it doesn't make sense from the cost per case. It doesn't. The cost analysis for my hospital is it is too expensive. That is still the case. And I think the technology will probably evolved to make it a little bit cheaper for us to be using in more patients. And as you said, Krishna, I'm an extremely skeptical person about robotics. Extremely skeptical. But now, seeing the hip, it wasn't the knee which sold it to me.
The same here for us, sir. Even for Sunshine, after seeing the hip, we took the Mako.
The true role, Mahesh, for a robot is on a uni. If you're doing a uni,
exactly, I agree.
It is fantastic. But I have used it for my knee replacements as well. You know, I used navigation for several years, and we hardly do any manual surgery at our place. But if you use it, then you will be able to judge it. So a lot of us make judgments without actually using the technology. Navigation, a lot of people have used, they found it's not useful, whatever. But I think you should pass a judgment once we use the technology. Currently, evidence, I don't think is there for a TKR or a THR at this point in time. But unless somebody uses it and publishes the outcome, no evidence will ever come. So technology, I feel, is inevitable. So we have to
one aspect Mako is it has got 225 publications, long-term publications.
Yes, sir.
And also, I think I just find it exciting to watch. I haven't used it, but with whether I would like to use it, most definitely.
So definitely,
I think the robot is the part where you're operating. Maybe that is acetabulum, and then you may not be worried too much about a big exposure because robo is going to do everything. You don't have to identify a particular landmark. Maybe uni because you don't want to expose too much. But in a TKR, when every bone is exposed in front of you, then robotic doesn't have much sense. It's like robotic is more important for, say, a brain surgery or surgery, say, prosthetic surgery, where you don't want to expose the whole soft tissues and, you know, see the picture. So that's where robotic will work. In TKR, I don't think it has much relevance. THR, yes, definitely more than TKR. Uni, definitely more than TKR. Because uni, you do not want to expose more, especially back of the tibia, you sometimes don't see at all exactly what you're doing. So
yeah,
I think it's good technology provided is available.
Yeah. Sahil, I think we are running extremely late.
Sahil also had something to say.
Yeah. Just one quick
Sahil.
It's a single ream technique. So often when you have those thick medial osteophytes or the hypertrophic cartilage where you want to reach the true depth of the floor. So we ream slightly more medially or vertically in those cases. So how does the robot take care of that single ream technique in such situations?
Yeah. So we don't need to do that here because when you do that, you're trying to reach the quadrilateral plate, you're trying to reach to the teardrop, right? You're trying to reach the true floor. You know, all that is determined beforehand where exactly your cup's going to be. Because if you don't do that in manual, you're going to be too lateral. So you may be in a right anteversion, maybe in right inclination, but you're going to be too lateral. Here, you've already told the robot that I want my cup to be exactly in this particular position. So it will take you there. You don't have to go medially and then start going into your particular anteversion. It's going to take you directly where you have planned. So there's a single ream. You don't have to worry about that hypertrophic bone or the cartilage at all. It directly takes you to where you need to go.
Okay. So thank you, sir. I think we'll proceed with Dr. Vijay Bose's talk on acetabular reaming technique. So I just hope it is now. Is it visible?
Yes, it's visible.
So good evening. Firstly, my thanks to Mahesh and Sahil for inviting me for this program. It's always a great pleasure and honor for me to be part of the Maharashtra Orthopedic Association proceedings. And greetings from Chennai. So my topic today is acetabular cup reaming technique and cup cushioning. So I understand that this is meant for primary hip arthroplasty, and so I'll stick to very much basics. The first question one should ask is, why should one ream the bone in a non-centered socket? Now, when I ask this question to enough trainees and fellows who come, the invariable answer is they say to expose the cancellous bone. Now, exposing this cancellous bone is, of course, important when you have cemented socket when you need interdigitation of the cement with the bone. However, for non-centered sockets, the reason to ream is not to expose the cancellous bone. Then why should you ream? There are three reasons for it. First is that no matter which indication you're doing the cup for, you must get down to the true floor. That's absolutely fundamental principle. That's the reason why you ream. Reason number two is that to change the hip center as required by eccentric reaming. We know that in various pathologies, the hip will remodel based on the pathology and migrate in any one direction. Now, to bring it back into where it was, we had the eccentric reaming of the eccentric socket to now make it concentric again. So that's the second reason why we ream. The third and the most important reason is to maximize the post-bone contact. So if I just take a cup and then jam into the socket without reaming, it just get point fixation here and there. So the post-bone contact is very small. However, if I ream the socket, make the socket the same shape of my socket, then my host bone contact will be huge, 90, 95, 100%. And that's the reason why you want to ream or maximize the host bone contact. It's very important that you understand this principle, and then only you start applying it during the surgery. The next thing is, how do you achieve stability in a non-centered socket? Three principles. First principle is to get AP capture. Second thing is to take away the toggle, or what we call as achieving toggle resistance. And the third principle is to use the smallest size possible, especially in young patients. You cannot just ream away bone, saying I'm getting this kind of stability or that kind of stability. You have to use the minimum size of the socket that is possible. We talked about AP capture. So the AP capture refers to engaging the socket with some portion of the anterior bone with some portion of the posterior bone. And whenever you refer to a socket size, say the socket size 52, for example, we're referring to the AP size. Now, normally in X-rays, because we're used to interpreting it on X-rays, we always put the template and we think it is the superinferior diameter. But that's not true. When you say a dimension or diameter of the socket, you're referring to the AP diameter, which usually is the smallest diameter. Now, when you ream, the first objective is to engage some part of the anterior with the posterior bone. So that is engaging the minimum diameter. So once you engage the minimum diameter, how do you know you engage the minimum diameter? If you put a trial, you will not be able to rotate because it's engaged one diameter. However, it may have some kind of a toggle, usually in a plane that is perpendicular to this AP capture plane. So although you got AP capture, you may still have some toggle because no socket is perfectly circular. Usually it's some kind of oblong shape. Therefore, to eliminate toggle, you need to do something else more because the socket is oblong. So remember that the socket will fail if you don't get AP capture. So if somebody here thinks that they can just put a socket in and put lots of screws to hold it like a picture on the wall, that doesn't hold. So toggle refers to a tilt that occurs usually in an axis perpendicular to the plane that you have got AP capture. So toggle is eliminated by getting a third point. So once you get a third point, so minimum 3 points you will not get any toggle. So you get AP capture plus you will not get any toggle. So the minimum requirement is to get 3 points. This is what we call as 3-point fixation. So eliminating toggle is usually by upsizing the cup. Now, as I told you, most sockets are slightly oblong, not perfectly circular. Therefore, when you put a circular socket inside, you've got an AP capture, but there is still some space along the oblong axis, and therefore there will be some toggle. So how do we eliminate this toggle? Usually in primary situations, you just upsize the cup by 2-3 millimeters, and then we've got a third point fixation, and therefore there's no toggle. This is what we do in primary. Although we do this, most people do not recognize it and they just blindly put cups. But only when you start recognizing this, you start applying these principles in practice. So here is a video. You can show that I got AP capture. I'm not able to rotate the trial, but still you can see the toggle appearing in an axis that's perpendicular to the AP capture axis. So how do I eliminate this? I just upsized by 2 millimeters, bigger socket, and now you can see that there is no toggle as well. It's rock solid, yeah. So that's how you achieve a 3-point fixation in primary sockets. So if cup cannot be upsized, a minor toggle can be eliminated by screws. Usually in a division scenario, we'll find no more bone for it to upsize, but still a minor toggle is left, and these can be eradicated by putting screws. This is the role of the screws. So you shouldn't think that the screws act like nails when you hang a picture on the wall. The role of the screws is to eliminate a minor toggle when you cannot expand the cup any further. However, if you have major toggle means you have toggle more than one plane. That's a major toggle. If you have a major toggle, then you need to have something structural. The screws will not suffice. You need to have something structural to overcome that. Usually, you have to put a structural bone graft or a metal augment to manage that scenario. And there are only 4 variables in cup positioning. 1 is the depth of the medial lateral position. 2 is the height of the superinferior position. The inclination of the version. I'm sure everyone is familiar with that. But what people are not very familiar with is what is the indices that we use to gauge all these variables. So with the first 2 variables, For medial lateral placement, otherwise called as depth, the index that we use the Kohler's line. So anything that we say is either too deep or too superficial, it's reference to the Kohler's line. And we talk about supra-inferior placement or the height, the landmark that we use, inferior limit of the teardrop, say the cup is high or low or whatever. So these are the indices that one uses in reference to for these terminologies. You can see here, the left side you see a cup that is far inside, much deeper to the Kohler's line, so it's a very deep cup. Here's a cup that is more superficial to the Kohler's line, so it's a very superficial socket. And here you see the height of the socket placement. Here you can see a very inferior placed socket, much below the inferior limit of the teardrop. And here you see a superior placed socket, which is above. The inferior edge of the socket is much above the level of the inferior limit of the teardrop. So this variables, middle placement and the superior inferior placement, will affect a lot of things in your total hip arthroplasty. The limb length, offset, abductor power, the impingement, the gait pattern, and trochanteric symptoms. So you've got to be very careful in both middle placement and the superior inferior placement. Now, we have two other variables, the version and the inclination. So the version is in reference to the anterior pelvic plane. Now, most people think that the version is the frontal plane. It is not the vertical. No, it's not. It's the anterior pelvic plane. Anterior pelvic plane is got by a plane which joins both the ASIs with both the symphysis pubis. That's the plane. So it's a slight tilt to this plane. It's not a vertical plane. And therefore, any further tilt due to spinal pathology usually will cause a problem with version. That's the problem that we have in any spinal deformity, whether it is Ang-Spawn or somebody's got spinal fusion, the pelvic tilts more. And therefore, there is a versional problem, which probably we need to give compensation based on various indices. And for inclination, the index that we use is the interteardrop line, which is the line joining the bottom of both the teardrops. Now, the cup inclinations, whether above or below this level, the inferior edge of the cup. Now we know to describe that particular cup, whether it is more inclined or less inclined, etc. Now, pelvic obliquity. In a pelvic obliquity, obviously, it will have an impact on the cup inclination. So whenever you have pelvic obliquity on the X-ray, you must be careful about the inclination of your socket. So these are the indices that we described. So this is the Kohler's line, which regards the depth. So in reference to the Kohler's line, we say that the cup placement is either too deep or too shallow. And then with regards to the inferior edge of the teardrop, we call it either the cup is high hip center or placed abnormally low, and that's the reference point. The two other lines you must draw on the post-op X-ray. One is a line joining the edge of the cup, medially and laterally, another line joining the base of the head. And if these two lines are parallel, that means that your version and inclination both are right. This is what we're shooting for today. I want all my post-op X-rays to look like this in the Kohler's line, refers to the inferior edge of the teardrop, as well as the version and the inclination when I have these two lines parallel to each other. That means I got my cup position perfectly correct. Now, however, there are other situations in which you got to modify your cup placement, and these are some of the examples. When you find an operator foramen is very open or cat eyes open, as Rana has described, or you find the operator arm being very close or the cat's eye being very close, or you have a dysplastic situation in which it's a long socket, the superior inferior diameter is very large, the antero-posterior diameter is very small, that's what it was dysplasia, or in a situation like protrusio, where you find the bone as remodeled medial to the Kohler's line. So all this will need some modification of cup placement, but the principles remain the same. So another important point that we have in recent times is that the conventional concept of taking the acetabular parameters in isolation and the femoral parameters in isolation, restoring them, does not work anymore. And today we are looking at a 3D balance where we have a combined, only thing that are relevant today is the combined relationship of both the acetabular and the femoral parameters. So that's what is very important today. And we have three parameters, combined version, described around the door, and then there's the composite length, and there is the global offset. So individual parameters of socket and femur are not valid anymore, and we are interested only in the combined parameters. So in conclusion, I'd like to tell you that the acetabular component positioning is the most important variable influencing outcomes of the THR. The functional safe zone, otherwise called the CSI, or the combined sagittal index as described by Larry Dorr, is more important than Levenick safe zone. We're talking about Levenick safe zone for the last 50-60 years. That's not valid anymore. Now we're talking about the functional safe zone. Individual femoral acetabular parameters are irrelevant today. Only combined parameters are relevant. And there are three indices that I just talked about, which we take the combined parameters into account. And then the parallelism of the component in the coronal plane, with the patient standing, when the acetabulum on the head is parallel, that is the position that you're shooting for. That means that you got both your version and inclination right. This is what we aim to do in 2021. So thanks again for the opportunity, and I wish you all a good evening. Thank you very much.
So that brings us to the end of the last talk of this webinar. Any parting comments or statements by the faculty?
Others, do you want to comment?
I think, sir, that's a wonderful, of course, a conclusion of how to do the acetabulum by Dr. Vijay, sir. So, but wonderfully organized.
Message from today's
It
webinar.
is pretty clear. The 2 points, AP capture and superior inferior toggle, how to address that and recognize it intraoperatively are extremely important to get a stable uncemented fixation. Dr. Bose talked about it. TAL, I think, still is a good landmark for acetabular cup placement in a lot of situations. And I still feel there is some relevance of restoring femoral and acetabular. Beverland's concept of Vijay's point on neck length and offset using the same implant. So here, Dr. Harish is important and relevant because we must tailor the implant to the patient, not the patient to the implant. So we must choose the correct implant for that particular neck shaft angle and the neck length of the patient. Otherwise, we are forced to look at combined parameters like combined acetabular femoral length and combined version of acetabulum and femur.
Yeah, perfect. Thanks. Sahil, do you want to conclude today's webinar? Or?
Yeah, I think so. Just good take-home messages for any primary total lap arthroplasty. As long as you stick to the basics and get your positioning right, component placement, soft tissue balance, I think that would mean that the patient is happy for the next 20, 25, 30 years. So if you do your primary surgery right, we're looking at a good longevity of the implant and the outcome of the patient as well.
Yeah. So I think I thank all the faculty on behalf of the Maharashtra Orthopedic Association, Dr. Nitin, who was the convener, the observer for the credit from the Maharashtra Medical Council. Thank you, Krishna, Kiran, and Dr. Adarsh for staying for a longer duration. It's almost impossible to actually complete the webinar in time. But I think the main credit of organizing this webinar actually goes to Dr. Sahil Sanghavi, who is a young dynamic surgeon who is interested in education, which really helps us all to get together and discuss new things and new techniques in arthroplasty. So Sahil, do you want to conclude and call it a day?
Yes, thank you. So that brings us to the end of the webinar. Next Sunday, we'll be having the advanced hip arthroplasty session, where we aim to cover some topics related to revision and periprosthetic joint infection. So I look forward to having you all with us for that webinar as well. Thank you.
Thank you very much. Thanks.
Bye. Stay
safe.
Bye,
guys. Thanks.
Bye. Good night.
See you soon.